Good morning, everybody. Are we ready to start? 9 o'clock? And ready to live stream, if we are. So, we're going. So, welcome to our board meeting, 25th of July, of course. And just a reminder to everybody that we are meeting in public today and that we are live streaming. We're going to run our agenda slightly differently today, so let me just, by way of introduction, tell you how we're going to run. The first item, unusually for us, we're going to have a special first item before we do the standard things like minutes and matters arising and all that stuff. And that's going to be the NSFT mortality recording and reporting paper. And let me go through how we're going to do that first item, which, if we get it right, will last about 45 minutes or so. And we'll probably have a short break after that before we then go into the formal, normal business, if you like. So first of all, Lisa will present the ICB's paper this morning. And she'll introduce that on behalf of Andrew Kelso, who's away on holiday, so has given apologies for today. So thanks, Lisa, for doing that in anticipation. There are 7 recommendations in that paper, as you will have seen. And at the end of the session today, excuse me, our objective will be to review those recommendations and either approve them or otherwise. But after Lisa has presented the paper, I'm going to go to Caroline and Emma. So welcome to the meeting, Caroline and Emma, and we look forward to your presentation, which is entitled, and again it's in the pack for you, Forever Gone, Losing Count of Patient Deaths. After Caroline and Emma have presented, we'll then open up to the board generally. We'll start with a response from Stuart, as a board member, but from NSFT, of course. Then from a response on behalf of the ICB from Ed. And then we'll go open for comments, questions, response, thoughts, board members' contributions in the normal way. We'll then go specifically to questions from members of the public on this specific item only, not on other items, but on this specific item only. And that would include you, Caroline and Emma. If you've got a question that you want to ask the board, that would also be your opportunity. At the moment, we only have one question from a member of the public, from Anthony Dooley, which we'll cover then, and Simon, I'll come to you under that item. Ed will answer. We'll then go back to the board, the wider board discussion, and then we'll see if we can approve or otherwise the recommendations in the paper. If we get that right in our 45 minutes or so, we'll then have a break while we slightly reorganise and go into the meeting proper after a short break. Everybody happy? Excellent. Thanks for that. So, a few formal business items before I go to Lisa. I've already introduced Caroline Aldridge and Emma Corlett, so welcome to the meeting. We have some colleagues from GT present today in case there are questions. So welcome to Matt Custance and Chris Giles. Other visitors today we'll introduce as we go along. Apologies. Joe, I'm going to come to you for the apologies.
Apologies have been received from Kirsten Alderson, Dr. Ewan Cameron, and Craig Black is here on his behalf, Sue Cook, Jeff Dobson, Steve Feast, Andrew Kelso, Howard Martin, and Chris Armour is here on his behalf, and Nick Rayner.
Thanks very much, Joe. And then, I've already alluded to it, of course, but questions from members of the public. We do have the one I referred to from Mr. Dooley. Simon, Joe, are there any other questions from members of the public? No from Simon?
No.
And a no from Joe, so just the one at the moment. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we're already aware, of course? And no declarations of interest noted. Thank you very much. In which case then, into item 4, the NSFT mortality recording and reporting paper. Lisa, all yours.
Thank you, Chair. So I plan just to go through the process of the review, the key issues, and then spend a little longer on the recommendations that Grant Thornton made. I do want to just start by recognising, though particularly in a live streaming environment, that when I talk about data and process, that means much more to people that may be watching, and that means people's relatives, people's friends and people's lives. And I just wanted at the very beginning to highlight in section 1.6 we have commissioned a listening organisation to be able to respond to people that want to contact. It's a listening service called Just Be, who are an independent charity. So I would urge anybody that feels that they need some support whilst listening or after listening to this agenda item to contact that charity. So the background to the review, last year NHS, Norfolk and Waveney and ourselves as an integrated care board were asked by NSFT to commission an independent review to assess the mortality reporting at the Trust between April 2019 and October 2022. In the September, we commissioned Grant Thornton to undertake the review, and the review was commissioned for a very specific purpose, to provide an independent audit of the processes used by NSFT to collect and report data relating to mortality. In February 2023, Grant Thornton produced a draft of the report, which was shared with NSFT and the ICBs to check for factual accuracy, and the report was then published on the 28th of June 2023. You have a copy of the report in Appendix 1. The key issues that Grant Thornton concluded through their review were that NSFT has strong governance in its approach to inpatient deaths. I think that's a really important distinction to make, and a point that I'm sure Caroline and Emma will pick up in their reports. However, the Trust needs to bring the same rigour to improve the processes around the reporting of all mortality and the understanding of all deaths for patients on its caseload or within 6 months of discharge, and that's particularly for deaths in the community. Grant Thornton found that the process of categorising and grouping expected and unexpected deaths and the decision-making involved was unclear and inconsistent, which has led to questions of clarity and a potential resulting lack of confidence from external stakeholders. For cause of death information for community patients, more needs to be done by other providers to support NSFT to access information, and both ourselves as an ICB and other providers will need to support NSFT within the health system to make that information accessible and available. I think it's fair to say that the ICB shares concerns regarding the large number of unexpected deaths for which a cause of death is not available, and the lack of verification over classification of death. And we are all very committed to making sure that going forward this is resolved. I think I just also wanted to highlight that there has been concerns raised that the action plan is not complete and was not co-produced with patients, families or bereaved relatives, which is something else that we seek to address. So moving on to the recommendations. The ICB board is asked to approve 7 recommendations. Firstly, to offer sincere condolences to the families and loved ones of all patients who have died. Secondly, to receive and note the report by Grant Thornton and the action plan by NSFT. Thirdly, to commit to work in mutually meaningful co-production with NSFT, patients, their families and communities and bereaved relatives to make the recommended improvements and any further improvements that may arise as we go through that work, and to ensure that the Trust uses the right processes to accurately record and learn from deaths. Fourthly, to commit to work with NHS Norfolk and Waveney, ICB, NSFT, patients, their families and communities and bereaved relatives to better understand the deaths of patients under the care of the Trust or within 6 months of discharge, both retrospectively and in the future. Number 5 is to review and co-produce with the Trust and patients, their families and bereaved relatives an action plan that considers the concerns raised since the publication of the Grant Thornton report. Number 6 is to note that assurance of completion of the action plan will be provided through the NSFT Oversight and Assurance Group, which NHS England chairs, and also each ICB will report an update on the action plan through the Quality Committee. And lastly, to agree in principle to a follow-up audit of mortality data recording processes in April 2024, following completion of the action plan.
Okay, thank you, Lisa. So we'll just hold discussion on that at the moment, and then I'm going to come to Caroline and Emma. So it's over to you. Are you ready for it? Yeah. Okay.
Thank you. I'm Emma Corlett. I'm one of the co-authors of this report that we've written in an independent capacity, but just for transparency, I'm a county councillor based in Norfolk, and I was a mental health nurse at the Trust for 17 years, working in both Norfolk and Suffolk.
Yeah, and I'm Caroline Aldridge. I have worked for the Trust. I was working for the Trust when my son Tim died in 2014. I'm accidentally an activist and a campaigner, and I've written about my experiences and other people's experiences. And I think it's really clear to say about why we wrote this report and how we wrote it. So we've written it in our independent capacities along with Anne Humphreys, who can't be here today. Although we've been members of various campaigns, we are not writing it in that capacity. It was us as 3 ordinary women, really. And it's our response from having followed 10 years of mortality at NSFT and of raising concerns about the data, the figures, the way things are done. And then when we looked at Grant Thornton's report, we felt there was some really important stuff that we needed to add to that and to give voice to the bereaved relatives. So I don't know if our PowerPoint is able to come up. Is it? There you go. So we've just introduced ourselves. So we just really want to say again that we're standing here on behalf of bereaved relatives that we all have supported. And Norfolk and Waveney did a silence at the beginning of their meeting, and we worked out that if we did a minute's silence for every one of the 11,379 deaths in the last 5 years that NSFT have produced in their figures, we would be sitting here silently for nearly 8 days, just to set it into context. Okay, so we've come at it with both our lived and professional experience. I should have said I'm a social worker by trade. I've been a lecturer, I'm a teacher, so we come at it with all of our different personal and professional experiences. Any of you that have looked at Grant Thornton's report, and hopefully the board all have, will see that there's an overwhelming number of points in there. It's just thing after thing after thing that takes your breath away. We believe we hold the organisational memory, and what we've done with our report is underpin it to evidence. So we've hopefully, although it's long, it's hopefully an easy and accessible read. It's all linked to evidence, and we open it with an open letter to the Secretary of State and the Minister asking for their intervention. Then we've given you an executive summary and the long read evidence, and we've put in appendices where needed. So fundamentally, when this was first announced that Grant Thornton would do this is in their statement of requirements. It said verifying the number of deaths. And quite quickly, that disappeared off the agenda. Now, we knew that was impossible because that was the point we'd been raising, that we didn't think anybody would be able to come up with a number. And last week, Grant Thornton, we're really grateful they provided us with a clarification email which adds a little bit more detail to their report, and it's really clear then that they were unable to provide that assurance over numbers because of the quality of the data. And I think we were probably not shocked but further disappointed to see that the information was provided late to them in the project, and that when NSFT provided it, it was inconsistent and incomplete information. And we hope we fill in some of the gaps in our report with the stuff that we've gathered over the last 10 years. We cannot underestimate what this means for the families. The message is that their loved ones are not worth being counted. And a bereaved daughter said this to me: the trust should know the exact number and name of every service user they failed, because the loved ones left behind will never forget. So we've been tracking this for years. The stuff that we have got a bit cheesed off, I think it'd be fair to say, with the idea that we might not understand the data. We kind of respectfully suggest that we've been following this very, very closely for years, and we probably understand some of the issues with the data better than some people whose paid job it is to do so. We've noticed all the conflating of terms, the changing methodology, and the discrepancy in published figures. And it's truly shocking to see people like NHS England who've accepted figures that don't make any sense, that should have been a red flag. So just then to summarise what Lisa was saying, we believe all the figures being produced now are fundamentally flawed because of the journey they go on. Grant Thornton said there was no end-to-end journey, but what we know is that the notification of deaths are unreliable. They're not counting them all at the very beginning. Then they're not being categorised correctly. Then there are multiple errors as it goes through its journey to being underrepresented at the board, and the external data doesn't match with internal. So downstream from that very first point when somebody dies, the problems are compounded, and at each level the data, in our opinion, becomes more unreliable. And the minimisation we've seen about the deaths has really distressed bereaved relatives. So I'll give you an example. There's a bereaved mother's quote up there, but I'll give you an example of someone I spoke to last week who is deeply distressed because in their serious incident report, NSFT say that they accept that there were failings in their care that led to their daughter's death. This is a 19-year-old. But by the time that came to the board papers and the annual report to NSFT, it says there have been no deaths due to a failing in care. So literally, they've been disappeared out of the system, something that should have been a concern. And we're very concerned about the use of natural and non-natural when NSFT did not even know how somebody died, because we don't believe there's anything natural about these deaths. We think there's been an oversimplistic explanation about, one person attends a memory clinic once and dies of a stroke 3 months later, which doesn't reflect the complexity and the nuances of comorbidities and the way physical health and, say, serious mental illness are interlinked, and there's lots of research evidence to suggest people with serious mental illness die earlier of physical problems. We think the data is missing key information. We won't go through all of this, but really shocking around stuff like not capturing protected characteristics. So we know that the Trust couldn't answer simple questions like how many of your black patients have died, or how many people with a disability have died. And we think there's an urgent need for both the ICBs and NSFT to undertake a quality impact assessment. So these figures on the screen, these are the ones that NSFT produced on the 28th of June alongside Grant Thornton's report. Now, we believe that was quite ill-advised, and it showed to us that they hadn't recognised the gravity of the mess they were in, because if you look at our streaming from the beginning down, all the figures are flawed, so none of the figures can be correct because they're not capturing them at the very beginning. But then we will also notice things in this that we were really quite concerned about. Again, it's a different methodology, having been criticised by Grant Thornton for continually changing this methodology. This looked at 5 years when Grant Thornton looked at a 3.5-year period, so you can't compare like with like. But we think the focus on suicides, several concerns with that. One is it's conflating mental illness-related death with suicide, and we know there's many, many other sorts. Also, the way that suicides in the data are just those where the coroner has given a verdict of suicide or took their own life. And we're in a public forum, and I won't give details, but suffice to say, lots of people die by their own hands, and what it says on their death certificates will be the means by they did it, not suicide. So that's missing a whole group of people. We were also pretty alarmed at the way that 21 prevention of future death notices were issued in that 5-year period, and that appears as 13 because of the way the data has been manipulated, and we can explain that, and we explain it in our report. And we felt actually, though, it was missing the data we needed. That, you know, the inpatient data talks about just the suicides, when we know that, so there's 0 and 0 suicides, inpatient deaths in the last 2 years, but we know there were 5 prevention of future deaths notices for inpatient deaths in that period. So we looked at it, and we won't go through this now, but we've come up with a starting point for the data we need. So on the left, you see the data we are able to get in the public domain, and that's worth saying that everything we get is just what's available in the public domain, so we know we're missing. So in our report is flawed in that we only have the data we can get hold of. And then on the right, we've suggested what might be more useful data for bereaved families and the public and people like the ICBs to have, so that you can consistently track what's going on. But we believe working on what that data is needs to be co-produced, that actually people need to sit in a room and think about what they want from this data and what's going to make it useful and effective. There were bits missing from Grant Thornton's report, and we think these are needed if we're having a comprehensive view of mortality data. So prevention of future deaths were not in there. Interestingly, they're not in the Trust's learning from deaths policy either. So a fundamental learning point, but it's not in the learning from deaths policy. But commitments are made to the coroner that they're learning from them. The Trust used the real-time surveillance programme for suicides, and we asked Grant Thornton why they didn't comment on that, and in their email they told us because they weren't made aware of it. Likewise, NRLS, which is a lot of the data that NSFT use are often the NRLS figures, which are a very small subset of their deaths. And again, it wasn't in there, but Grant Thornton did say that they found that the trust completion time for NRLS was longer than the average time for trusts, and this correlates to a whole load of warning notices that had come out from NRLS to NSFT that are freely available on the internet. So we are a little bit puzzled why that then didn't go into the report, because we think it's important data. We think, and we've had an apology from Grant Thornton, and we're grateful for that, that there was obviously nothing in their report that even mentioned this being about people. But more shockingly, the action plan doesn't mention people either, or the impact on bereaved relatives, or even the impact on service users and carers who want to stay alive, who are now quite worried about what your chances of coming out alive if you go get some help. So we feel that's got lost. We think there needs to be some reparation, and there should have been preparation for this report coming out. And we're grateful that the ICBs put together the helpline, but actually somebody should have thought about that before the report came out, that this would have a significant impact on bereaved families. We think NSFT's responses have kind of shown a digging in mentality rather than a reaching out, but we are still willing to try and work with them to see if we can change that. And obviously there's been no public apology from NSFT. So we've got some questions for the ICB to consider, which we're just going to whiz over. They're in the PowerPoint, which you've got, so you can look at them at another thing. So we're just wondering about why this matters, and what your priorities are in resolving these issues, And how will the mortality data be fit for purpose and understandable by all? Now, with my teacher hat on, I know if somebody can explain something to me simply, it means they understand it. And I believe that's what the mortality data needs to be for everyone. Whether you're in government, NHS England, on a board, or sitting on a park looking at your Eastern Daily Press, those data needs to be understandable so that we can all see what's going on. And I believe it's possible. So I'm now going to hand over to Emma.
Thanks, Caroline. So I'm going to focus more on the governance aspects, which in our view, what is described in the body of the report actually describes what I would consider to be inadequate governance. Mortality is almost invisible within the Trust's BAFs, the Board Assurance Frameworks. There isn't a category on mortality, and we're concerned what message that sends sort of within NSFT and to the wider system. Norfolk and Waveney ICB have now committed to including mortality in their BAFs, and I think an ask for you would be we would think it's important for this ICB to consider doing the same. Strong governance. As we flagged up in our report, what is in the body of the report, we don't think always tallies with what was in the summary and the conclusions and in media statements that were put out. It was helpful to get the clarification email from Grant Thornton, and as Lisa mentioned in her opening, saying that the strong governance related specifically to inpatient deaths. I don't think that was made explicitly clear in the press statements that went out or how they were reported. And I think we struggle. It really is the bare minimum and not a cause to congratulate yourselves if you manage to be able to count deaths that occur on your actual premises. I don't think that's cause for putting out in a media statement and saying how positive that is. I think that's the absolute minimum we should expect of any NHS organisation. And our view is it attempted to gloss over the fundamental flaws that were found in relation to community deaths. And I'll flag up again, in the body of the report, it says that there was little evidence of interrogation of the data, routine or areas of concern in that wider governance within the Trust. And, those are the things I think that are key for the wider system to focus on. So we've just, to try and keep focus on, we're talking about families, we've just put some of these quotes in from families I'm not going to read out, just to capture for you some of the impact. We've been contacted by lots of families since the report was published, just so you can see the kind of things that people have been saying to us. So again, these questions aren't, they're more self-reflective things we'd like you to consider. There's been lots of changes, lots of external oversight intervention, yet here we still are. So what needs to happen for things to change? If there are positive changes, how will they be sustained? What we've seen is things may be improving in one area, but then when the eye is taken off the ball, that kind of unravels and focus needs to be put on something else. And as Caroline said, how can the public know and be assured that mortality data and scrutiny is accurate and is genuinely being used for learning? And I'll bring that back to why we think the prevention of future deaths notices, we've looked at the themes of those, and it's deeply concerning that subsequent prevention of future deaths notice have similar themes in them. I've also sat and supported families at inquest where prevention of future deaths notice have been avoided because the Trust solicitor has told the coroner that change has already been implemented, therefore the coroner cannot issue a prevention of future deaths notice. And there doesn't seem to be any external checking whether that's actually correct, and whether, if those changes have been made, whether they've been sustained, or how an impact of a change is being measured. We think they're really massive gaps that need closing. So I guess our challenge is, and we really like this quote about a restless board. So our plea to you is to be a restless board, one that constantly seeks to find out more and be curious and probing all of the time. And I think our observations over the last decade and the evidence we've presented on a report is that is not reflective of a restless board and a restless system. And we've had some commitment from Norfolk and Waveney to try and do that. Our report touches on, it's the whole system. It was a concern that the most recent CQC Inspection didn't look at mortality. There's no mention it in their report. There's, the information that we've managed to find, particularly in NRLS, where, and it's really easy to read, simple on one page, that even says this is a red flag. Where did that go? Where is the checking of kind of governance, internal to NSFT and external, on, corroborating what's being presented with other information that's available? And it's a concern that NHS England didn't seem to notice or challenge missing or contradictory mortality data in the annual reports. And Caroline details, and thanks to Anne for reviewing 10 years of the annual reports, but sometimes even within the same reports, what's presented is actually contradictory and doesn't tell a consistent or a coherent story. I think also in terms of external scrutiny, there's a difference between the two counties. Health Scrutiny Committee, which I am a member of at Norfolk, has had quite a lot of looking at this and wider NSFT issues. Suffolk hasn't. By comparison, Suffolk Health Watch seem to have been very engaged in the issues and have done some good pieces of work, but Norfolk Health Watch don't seem particularly engaged with the issues. So that kind of wider system failure, I think, is a real concern for us. And then bringing it up to more recent, we're talking about some very poor examples here, but we know that NSFT isn't alone. There are wider issues, national issues. There is going to be an HSSIB looking at mental health inpatient deaths, but like I said, our concern is, and has been for a long time, the total loss of oversight of community deaths. I've touched on this already. I said our concerns that what was in the body of the report didn't, in our view, we were puzzled by some of the stuff that was in the summary and the media reports. And I guess our question would be, that was a long period of time to check for factual accuracy. And again, thank you to Grant Thornton for clarifying with us. There was a change of the engagement team with them, which meant, as I said, they essentially had to undertake a comprehensive new engagement and feedback process. I guess my challenge is, how broad was the definition of factual accuracy checking? And we are concerned that there seemed to be, a whole new team changed in what happened during that period of time, which further lessens our confidence in the system being mature enough to take on board these serious issues. Caroline touched on our actions which are in our report. I won't dwell on those. I know you've got some actions on there, but I guess we would just urge people to look at those and see if anyone thinks any of those need adopting. And just some more questions to reflect on. I'm just going to hand back to Caroline to close. Thank you.
Okay. So we believe that co-production is the way forward. It's a real missed opportunity that the action plan wasn't co-produced and that bereaved families weren't involved. We're really worried that no further harm is done. We are picking up Norfolk and Waverley very quick to say, yes, we're going to co-produce. We know that various organisations have already started having conversations about who might do that, and we are not convinced that they understand the sensitive nature of these traumatically bereaved families. So it's really important that actually, from the very get-go, before anyone even commissions any co-produced work, we get people in a room together with the expertise in traumatic bereavement, mental health co-production, the ICBs, NSFT, and ourselves to think about what's needed, how that might be best approached, resource supported and evaluated. The bereaved families will need buffering. You just cannot go out and just recruit some bereaved families to help you with this work, because what we're having is people coming to us since this has come out who have been engaged with doing co-production work, who are now saying, and I'm just going to quote someone, am I just a helpful idiot? They're feeling like that maybe this is all tokenistic, and they're feeling further traumatised because that work might be the only thing that's keeping them going following a traumatic loss, the thought that they're making a difference. So we're more than happy to be involved with helping everybody work out what that might look like.
I'll just come in there. I forgot that was meant to be my bit. I just want to stress, you can't underestimate the impact that when you're talking about co-production, you are effectively asking families to put their trust in people and a system that has already failed their loved one. It's not the usual kind of co-production and approach. You know, these are people who have been traumatically bereaved, and I don't think there's been thoughtful enough consideration about how and who is best placed to approach that, because I think hopefully we can all agree, if you don't get this right, the last thing any of us want to do is pile any more harm and distress onto people who have already been harmed and distressed.
So obviously our worry then is that the system just reverts to normal. We've seen that. We cite multiple reports into deaths over the last decade, including the Verity report in 2016, where of the recommendations, some of them still haven't been implemented, yet the then CEO stood up at Norfolk Host and said they'd either been done or would be done shortly. We cannot be in this position in 5 years' time, in 10 years' time, when people are looking at Grant Thornton's report and our report and going, oh, look, we still haven't done it. It's imperative that there's some action now. We're really glad, Norfolk and Waveney rather blew us away with their unreserved apology. It was a bit of a surprise and very welcome. They also have given equal weight of our report. When we were at their board, they were talking very clearly about how the two reports complement each other and they would have equal weight in terms of their planning going forward. So last week NSFT did post an updated response to the mortality review, which is an improvement on their first response, massively so. We appreciate that, but it was kind of lost within another news item, but it's there. They still haven't responded to our report or apologised. So we think there's an organisational systemic amnesia going on, and we're not going anywhere. We're not going to move on, and we're not going to let you forget. We're just three ordinary women, really, who are those persistent and determined women that Robert Francis talked about, the persistent and families who just kept flagging up that something was going on here. And our question is, if we could see what was going on in plain sight, why couldn't the system see? Why couldn't any of you who are looking at board papers and annual reports and tenders and contracts, why couldn't anybody see that something was going on here that wasn't right? Because it's really, really obvious when you start looking. And it shouldn't have been necessary for it to be bereaved relatives to flag that up. And the bereaved relatives, they read Grant Thornton's report with very heavy hearts. Most of them can't even, it's too difficult, either because of the dense nature of it and there wasn't an easy read version, or because actually the content is just too upsetting. Some of the figures in there, people read them as they are. So the 278 people who died on the same day as discharge, we know there's a nuanced range of possible reasons for that, but that's not what bereaved families read. They just read, you know, you get discharged and you die. The big question for them is my loved one included in the figures? And we've lost count of how many people we've had distress coming to us saying, is my loved one in these figures? And we don't know. So I was at a conference, the King's Fund, earlier in the month, and Melissa Mead, who lost her young son to sepsis, has done lots of work around patient safety and cultures in NHS Trust. She said this: the best apology to bereaved relatives is change behaviour. And that's our challenge to you, really. We've had a lovely apology from Norfolk and Waveney, but what will matter is whether we see the actual change. Because otherwise it's, yeah, we're kind of a bit like, don't bother. You know, if you're just going to carry on as before, we've got other things we could do. And there's been a lot of truth. NSFT's deputy CEO stood up at Norfolk Host when this report was commissioned and said they did know the numbers, there was just a difference of opinion, and that this report would get to a single truth. And we would say, the one thing is certain, that those who've lost their lives are forever gone. They're not coming back. For these families, our loved ones, my son's not coming back, however much work I do around this. I don't do it for me, I do it for the others. But there are thousands of bereaved families across Norfolk and Suffolk who do live a single version of the truth every day. Their loved ones are dead. So we can leave it there, I think. And thank you for listening.
Okay. Caroline, Emma, thank you very much. So before we go to board debate and consideration of the paper and Caroline and Emma's presentation, let me go to Stuart and then I'll come to Ed. Over to you, Stuart.
Thank you, Will. Thank you, Caroline, Emma. I don't want to sit here and come out with loads of words that that don't mean anything. I do want to say how sorry I am, and I genuinely feel that it's not excusable that over a large period of time, NSFT, my organisation, has not been able to count the number of deaths in the community in a way that's meaningful to people, and I am genuinely very, very sorry that is the case. We do value your report, and we look forward. I know we're chatting later today, and you're coming to our board meeting on Thursday, which I think will, and quite rightly, be a challenging discussion for us as a board, and we welcome that. We do see your report as valid, if not more valid, than the report that we have from Grant Thornton's, because it's about people, and that's the reason that we all do the jobs that we do. So, on behalf of the trust, you know, I am very sorry, and I will say that on behalf of people who've been sat in my position many years ago as well, that this hasn't been good enough. The opportunity to co-produce something different, I think, is essential, because, you know, you give example there of what the data set should look like. Between us, we can do that, and I will absolutely give my commitment that we'll work with you to make that happen. So, big commitment to co-production in its truest form, and also, I suppose, I personally would like to apologise that the communications from my organisation has not hit the spot, and there's nowhere near being what we wanted it to be. Lots of reasons why, but there's no excuse. So I personally am very sorry for that. But really do value your honesty, your commitment as well. I know a lot of my colleagues in the trust particularly value your commitment, Caroline, and the work that you provide to support to them. But we absolutely need to make this right now. Thank you.
Thank you.
Okay, thank you. Over to you, Ed.
Thank you. Just to add to that, I wanted to thank you for your leadership and your courage coming forward to today. The scholarship in the report is exemplary. It's written in plain language. It's absolutely superior to the Grant Thornton report that we received. And you've done this carrying the bereavement of Tim. And you've supported many families in Norfolk and Suffolk to do so. So the strength of character you've all shown has been extraordinary. There's nothing ordinary about you. I just wanted to also issue a public apology. It should not have taken the local NHS 10 years to listen to you properly. And the consequence of that is we haven't been able to learn and improve and make a difference to families locally as a result of that period of time that's been lost. So I just wanted to issue a heartfelt apology for that failure. The third thing is the absolute commitment that Lisa described and that Stuart's referred to around meaningful co-production. We need to do this properly, learn from mistakes in the past, and absolutely work as a team on this going forward, and hopefully build some trust and some respect. But that's on us to do it.
Thank you.
Okay, thank you very much, Ed. So, colleagues, board members, questions, points, thoughts? And Paul, yeah.
Thank you. As you were talking, I wrote one line, which was, 3 elderly women, 1 extraordinary report. And that's generally how I feel about this. In terms of personal reflections, when I looked at our performance report, it mentions mortality but doesn't do it justice. So actually there is a question for me in terms of how do we report mortality, in what information do we provide within those reports, and what focus we give to the board. So I'll be working with colleagues to try and understand how we can capture some of that information going forward so that it's more visible in our reports. But there was one line in your report that struck a chord really when I read it, and you talk about a reparation plan. And I think you've already tried to articulate what that means in terms of the trust and everything else. But I'd be really keen to understand what does a reparation plan look like to you in terms of things. Our approach to it is probably far more important than a detailed plan in terms of approach and collective approach to that, which I think is what you're alluding to when you talk about more than just collaboration. It's deeper than that. I'd be quite like to understand what that means to you. Thank you.
Thanks, Paul. Do you want to respond to that, Caroline?
Yeah. You're right, a reparation plan is something really quite nuanced and complex, and it's about the way we do everything. So yes, there needed to be something in there that says we need to acknowledge the harm that's been done to bereaved families, about hearing this stuff and about losing their loved ones and how we might do that. But I think it comes from working in that much more genuine, non-tokenistic way and involving bereaved families and thinking about what it is they need to see to feel that they've been that apology is a behaviour, that they are feeling that there's something, but it's also about relationships. So one of the things for me that's been really hard personally over the last few weeks is, you know, it's fractured lots of relationships, you know, having to speak out like this. But I know that the only way forward is to still try and rebuild those relationships in order to work together. And, you know, I am meeting with Zoe and Stuart later today, and I'm really pleased about that because we do need to somehow get over this. And that's the reparation. So the bereaved families mainly are isolated. Most of them are silent. Most of them are isolated. And the reparation, we can't bring their loved ones back. But what they want to hear, what we hear from them over and over and over again is, they don't want somebody else to go through what they've been through. They want to be part of making a difference for people to learn. So I think the biggest reparation might be a really genuinely co-produced training programme, not just for the trust, because I think this is a system-wide problem, and I think it's a national problem. I mean, you know, we haven't really stressed enough here that NHS England, you know, we were kind of left reading all this stuff and thinking, what is the point of them? You know, what is the point of any body that issues guidance at whatever level, scrutiny, advice, support, monitoring, if actually they can't even spot the biggest red flag ever, which is people are dying? You know, what's the point? So we've got to work together, I think, is what I'm saying. I've probably gone off point.
Yeah.
Sorry.
No, I think the other thing to consider is, as we say, you know, part of it's about duty of candour, but you can't exercise it if you don't know who you need to exercise it to. And I think that is the point here. There are families out there who considered that their loved one died, and if you like, is an NSFT death that has never appeared in the data. So I think before you can even do co-production with bereaved families, the system has got to think of how you're even going to be identifying who you should be working with, and you are a long way from that at the moment. So I think don't underestimate the steps that actually need to be taken before you can even get, because, you know, we know the people we could get in the room now, but we know there's lots of people that we're not in touch with, and so that's the scale of the task, really.
Okay, thank you. I'm going to go Peter and then to Nick, and then I've got a few other names as well. So Peter first.
Thank you. Thank you, Chair. I'm Peter Devlin. I haven't got a name badge, but I work for Essex County Council, so I'm the partner representative for Essex County Council today. I found the report very powerful, very moving, and I think it was sobering in relation to bringing it back to people, families, and the impact that it has. So thank you for the report and the time that you put into it. The report itself recognises that the challenges that have been identified through the Grant Thornton report are not just about Suffolk and Norfolk, and actually that the issues are in Essex as well. So my question really is about how can we make sure that the lessons that are being, the recommendations and lessons and the issues that we've got in our systems in terms of reporting here in Suffolk and Norfolk are also, we're also using that to challenge what's happening in Essex to make sure that we have the best in place.
Okay. Again, do you want to respond, Caroline? Yeah.
I'm in contact with the families in Essex, and in fact in a book that Emma and I co-authored recently, we've looked at lots of people's stories, and some of those are Essex stories, some are Norfolk and Suffolk stories. Really worth having a look if you want that lived experience voice. We need to work together. So there's a real danger when we're asking for a public inquiry, Essex are asking for a public inquiry, there's a danger that the government will water it all down by just lumping everything in together. So that's both a danger, but it's also could be a possibility. It seems a bit pointless to look at it over here and look at it over here, particularly for SNE, where you've got Suffolk and Essex on your patch. I think it all comes back to relationships, collaboration, and it means everybody in this system, Norfolk, Suffolk, Essex as well, needs to set aside their boundaries, their differences, and be prepared to come together in a humble way and say, we've really messed up here. How do we work together? What are those lessons? So we were talking on the way here about Essex and thinking about the comparison number of inpatient deaths, and knowing that because we don't know the overall number of inpatient deaths at an SFT, we can't even do the simple calculation of per population whether Essex have got more or less inpatient deaths over the last 20 years than we have. And what really concerns me about Essex is nobody's even bothered about the community deaths. And I think one of the really important things Grant Thornton did bring out was how much more complicated it is to understand your community deaths when you're looking at somebody might die of a heart attack. Well, that's not a natural cause if it's caused by side effects of their medication or because they don't take prescribed medication because they're too mentally unwell. It's much more nuanced. As Emma said, you can count the bodies. So it's really shocking in Essex, they couldn't even count the ones that happened on their premises. But we think there's lessons across nationally, so we're not sitting here thinking we've got to beat NSFT up. We think what we've uncovered is something national. We've seen only today in the news that Cambridgeshire and Peterborough, what do you know? They haven't been looking into their suicide deaths. They haven't really got a clue what's going on there either. So I think we've probably just opened a can of worms. But it's around, if we want people to be safer and our population to be well and safe and happy, then we've got to look at this stuff.
So work together.
Yeah, work together,
Yeah.
Absolutely.
Okay, thank you, Caroline. Nick, and then I'm going to go to Richard. So, Nick.
Good morning. Thank you so much. Very poignant, very thought-provoking. I don't work directly in mental health services, but I'm very struck by how much of a read across from the experience, particularly around duty of candour and conversations that happen. But I think also about how we involve people in, as you say, the ambition to improve services going forward and to learn. I think as leaders, we need to take individual responsibility. So for more years than I care about, I write to every bereaved family of anyone that dies in the hospital and offering a meeting if they want to discuss anything that they're concerned about. The vast majority of those people said they wouldn't have contacted me had I not written. So I think there's some individual actions that we could take as leaders. But I'm not aware of the views of families who perceive that something that might have happened in the hospital was caused a death in the community. So that's a real piece of important learning for me. So thank you for that. I think the issue around co-production, how do we move from tokenism to really making a difference to the lives of the people that we serve? I don't know the answer to that. I wish I did. I think like most leaders battle with that constantly. But I think some training, as you say, but also the support that we offer to those people who we welcome into our professional world with their lived experience, and how do we support them, recognising that it's not tokenism, it mustn't feel like tokenism, and only real change can come from co-production. But really I just want to say a massive thank you to you and the whole number of people that have been involved in this, as well as coping with your own loss. To give of yourself and to give of your time to the service of others is remarkable. So thank you.
Thanks, Nick. Shall I take that as rhetorical? Yeah, thank you. Thanks for the support there for Caroline and Emma and the whole community, Nick. Richard?
Just a massive thank you to both of you for this. I know this is incredibly hard for you on a personal level. I've read both reports. I do think they're complementary, and it was a hard read, but I have to say it needed to be done. And for someone like Ed, who's worked here a long time, my personal apologies that it's taken this to get to this point. But I think it gives us really a good platform now to move forward and get this right once and for all. There's a couple of bits in there that I just wanted to pull out, if that's all right. One is that Learning from Death Forum. I really, really think we've got to get that right. Because I think you've both acknowledged that it's wider than NSFT. Nick's just said similar, that we need to look at this on a bigger scale. Peter said the same. I think actually we could really lead the way within SNE in getting this right, and getting this right for the rest of the country. On that point that you mentioned a couple of times in the paper where you've looked at best practice elsewhere, I think you mentioned Sheffield a couple of times. I just wondered if I don't think everyone's got this completely right, but are there areas that you would say you've looked at that we should be talking to so we can kind of learn from their experience rather than starting from nothing?
I will ask Caroline to respond to that.
Brilliant. We part of the reason our report is so long is we decided if we were going to do this, we might as well just get it out there, and it does form that platform. Yes, we have looked at briefly at other areas. We've got one pretty close by, NCNHC. They were looked at by the CQC as part of the evaluating how they were doing learning from deaths. And they've got a very different philosophy where instead of looking to see which ones they can exclude, they've got a consultant and a nurse look at every death. And then because they didn't have that many, they started saying, well, actually, let's random sample some that might not even be us at all to see if we're missing something. So it's a completely different culture and mentality about looking out. Sheffield, we've looked at, again, they're learning from deaths. They still don't mention prevention of future deaths either. So I think that might be a national issue that actually coroners are doing what they're doing and everybody just puts PFDs in a dusty box somewhere. Which is a national issue. But they have a thing in their board where they have a standing item where they look at whether they've got any bias that's influencing them. So we can say we know we're biased in what we wrote, but we're open about it. Their learning from deaths policy is interesting. It's much more family focused than NSFT's. It's got a whole section on thinking about how they work with families. I don't think it's a perfect learning from deaths policy. I think it's got a long way to go. But yes, there are people, and I'm sure there's more if actually we started looking, but you know, time and everything. But I think it would be really worth trying again to perhaps nationally try and get some people in a room together to look at best practice. Because nationally, if the conditions aren't set right, I go back to what's the point of people like NHS England, if they're not setting what it is you need to do and making it easy for trusts to do the right thing, then it's too easy for people to fall into other habits. And I just also wanted to pick up on you, Nick. When we met with Norfolk and Waveney, we had CEOs on that board from acute hospitals and community trusts, and they both said the same thing, that they felt there were learning points in here for their trusts. So I think it's bigger than mental health. And I know Grant Thornton, Howard, who came there, talked about, he was asked a bit more about the factual accuracy, but he also talked about the fact that trying to delve into mental health data is much harder than acute hospitals. So to be fair to NSFT, they're hard up against it, and the guidance hasn't been updated since 2017, national guidance.
Okay, thank you, Caroline. So I'm going to take Fanwell, then Susanna, Frida and Lisa, and then I think I'll try and move us on in the interest of time. So Fanwell.
Thank you, Chair. Caroline, Emma, thank you very much. I don't intend to repeat what everyone has said, but you know, this has been a very sort of, you brought to fore some of the concerns that, you know, we've always had around, you know, some of these places sometimes can feel like they lack empathy, and I think your report, especially with the focus on individual stories, is something that we need moving forwards. An area of concern that I have, you mentioned lack of diversity monitoring in some of the aspects of the report, and moving forwards we're talking about co-production. Now, one of the things that, you know, I think as a system we'll be looking at is, who do we reach out to, and you know, who needs to be part of this? Now, if as a system, you know, we don't even know who some of these people are, and some of those people don't even know that they've been failed, you know, my concern is how then do we co-produce solutions with them, you know, when there is that disconnect. And I think something that, you know, we need to work together and think seriously about how we achieve that. But thank you very much.
Thanks, Fanwell. Caroline, Emma, are you happy if we simply take that how to do the co-production challenge as a challenge to us all that we know we need to work on? Okay, thank you very much. Susanna?
So I do want to underline the exceptional quality of this work that you've done. It is extraordinary, actually. And what you've done is to, yes, underline the importance of the data, but you've really underlined the importance of the stories here. And we haven't got the end of the story yet. The end of the story that you want to see is the change. And as Ed said, your leadership in terms of you're talking about leading all stakeholders to work better together, to work together as a whole system, and that is what we're meant to be doing. You know, we need to do that as a whole system. So I'd be interested in learning more from you about how we need to work together in a better way as a system, how in mental health we can work together better, in a way that's really meaningful and tangible to people, because I think sometimes they find the idea of a system in health and care something that's quite hard to understand. We need to break it down into the nuts and bolts, and I've heard that in the room this morning. So thank you very much, and I think we've got more to learn from you.
Okay, and I'm going to assume you're saying yes, you'd like to help that
We'll
learning.
talk to anyone.
Yeah, I thought so. Thank you, Frida.
Yeah, hi Caroline and Emma, thank you so much. Now I won't repeat anything everyone's already said, but I'm actually in awe, and I don't think there's anything ordinary about either of you, to be honest with you. And what you've been through in this report is remarkable. I'm a GP, and I'm from Essex, so you know, but the complexity of mortality reporting in primary care hasn't been mentioned at all, and it is a real problem, and in part feeds into this report, and yet that hasn't been outlined, and I don't think we should forget, in terms of co-production, the role of primary care, and also my question as well is not just about the role of primary care and how we can play a part, because so much of the deaths happened in the community and were presumably certified by the doctors, GPs, and that didn't communicate to the trust. So there is some real issues there that hasn't been touched on today, which is throwing at me, like where is that? But the other thing I'd like to ask is, in terms of the new medical examiner creation, if you like, still delayed, unfortunately. I don't quite know where the delays are, but we are in process. How much difference do you think that would make in terms of mortality data gathering, I suppose? Would that be better than it is now? I can't see there is much now in terms of communication between primary care and the trusts. But how much would the medical examiner, once it's established, help, if at all?
Do you want to take that one?
Yeah. So the medical examiner, I looked at some stuff. It's not in the report because, you know, couldn't put everything in there. The amount of time the national guidance is for medical exams is so small. All they're going to do is sit on a committee, look at a few bits of stuff somebody feeds up. I think that's the problem NSFT have got within a lot of their governance, is that the people looking at the data have got numerous other jobs, and they might sit on a committee or they might do mortality data as a bit of it. So I think the medical examiner, I think, has a real potential to make a difference, but only if somebody's going to dedicate themselves to it. We were saying on the way here, we wondered whether anybody in Norfolk and Suffolk had looked at the prevention of future deaths in the way I have. I've got them printed out. They're my go-to resource. And so what we need is people within the system that have got that level of interest and curiosity in mortality to start unpicking the complexity of it. So we don't pretend we've come to all the answers here, because we haven't. We've only got some of the information. I think GPs are critical. I think there is a bit of an issue about how mental health related deaths come across, but that will be a national problem. GPs across the nation will have similar issues. And I think in terms of the role of primary care and co-production, when we're talking about we don't know who these people are, the one area that people are likely to have some contact with is their GP. The GPs will potentially be knowing who's been bereaved, and they will be looking at some of that. And I think for the ICBs, what you're missing is all the data that's not NSFT. So we know we're supporting people who haven't had a service within that 6 months, but still it's their mental health that's the absolute clear-cut reason they've died. But they legitimately wouldn't be in NSFT's data. But as a bigger system, I'm not seeing that picked up and flagged up, that you're kind of going, we've got a load of suicides here that aren't in contact with NSFT, or we seem to have a load of people with serious mental illness who are dying of cardiovascular disease in Ipswich, in here but not here. What's this about? So I think it needs, again, wider. And I think it comes back to it's everybody, and then it's also about how we do it. So too often we think co-production is we'll ask someone to come and sit in an endless Teams meeting while all the professionals do their etiquette and their little bit of stuff. And we think that that's working with people. We've actually got to see the whites of people's eyes. I believe, and if you work with me, Susanna, is about creativity. I would have you all making something here and get all those barriers down and connect with your emotions, and then go, now how can we relate as people? How can we connect and really start hearing and listening to each other? I think we need to do things differently.
Yeah,
Okay.
I think if I just quickly, I'd bring it back onto the data journey slide that we did. The role of the medical examiner, unless all of those flaws in data are sorted out, unless they're going to be there at the actual first point, we'll still end up with just a different person ending up with the same situation. But at the time whatever reaches them has already been minimised, you know, washed out, not included in the first place. So it's got the potential for being a critical role, but there's so much potential for things to be flawed before anything even gets to them. So I think I'm just sort of cautious about seeing that as, you know, it could be an important role, but it's not going to be one thing that's going to change. There's so many things that need to be in place to address the gaps that we've flagged up.
Okay, thanks. A quick response, Frida, then I'll come to Lisa.
Yeah, I think it comes down to education of those that sign as well at the cause of death, and that is down to the doctor's education essentially. And we're not taught about signing death certificates or how we define cause of death or the associations with the cause of death. We are just taught to write 1A, 1B. You know, I mean, I'm going down to detail, and I know this is not really about that, but it is something that about educating our juniors about actually really thinking about the cause of death, and actually in terms of 1A and 1B and 1C, actually writing that and not just seeing it as a job, a tick job exercise at the end of someone's life. I think there is the crux, is the education of my colleagues and myself, you know, all of us, but to sign these death certificates with more respect perhaps than, not saying that we don't show respect, but just more thought.
Curiosity.
Yeah. Okay, and that's what you were saying, really, wasn't it? Yeah. Lisa, and then I'll come to members of the public, and I know we've got 2 questions at the moment. So, Lisa, first.
Thank you. I just wanted to pick up on as we kind of redesigned the action plan, the importance of that learning forum that Richard, the Learning from Deaths Forum, and the importance of using that forum as an opportunity to have a real people-centred approach and not an organisational approach, because actually in the system we're still not great at that, and we really need to improve that. We need to understand the touch points that all these organisations had at different points with people's lives and the missed opportunities to have done something differently to mean that person didn't die. And I think that will take a real cultural shift for us as a system for different organisations. But I think the Learning from Deaths group has to be very people-centred and not looking at organisations, because we'll never realise the full potential of understanding that point we could have made a difference.
Thank you.
Okay, thank you. So I'm going to go to questions from members of the public, and Simon, you've got one, and then Jim, isn't it? Yeah, so over to you, Simon.
Thanks, Will. The first question then is talking about anti-Tucci, who's written that you will of course be aware of the findings of the independent review of NSFT, and the article in the HSJ entitled "Hundreds Died on the Same Day as Being Discharged, Trust Review Finds." You will recall the several occasions of previous meetings of the CCG when I invited you to say whether you had confidence in the management of NSFT, to which you not only said yes, but that you were working with NSFT to address issues and concerns. I wonder what your current view is following this independent review.
Thank you, Simon. Ed, would you like to answer that?
Thank you, Simon. So, I mean, I think I'll probably make 3 points to answer that. So, firstly, as we've just discussed, this isn't a singular NSFT issue. Obviously, they're at the centre of it, but this is around a whole system, cultural change that Lisa just described, a shift from being organisationally focused to actually one that's community focused that we haven't delivered. So I don't think it feels appropriate just to talk about NSFT singularly. However, NSFT is an organisation that has in recent times been marked as inadequate by the CQC. It's moved forward to requires improvement. And I think if you look at the Grant Thornton report and Caroline and Anne's report, it reflects that. It's an organisation that requires a lot of improvement. There are failures in governance and processes and systems that need to be improved. The final thing I'd say is that I've felt very strongly for quite a long time around the geography of NSFT, and I want to see a more locally based, a more Suffolk based mental health system. And I'd like to just recognise that NSFT have supported that shift and are supporting that shift. We've recently established a mental health collaborative for Suffolk, and we're seeing new models of integrated care, new relationships, and NSFT ceding some power and control in the interest of the community. And I think the two things going forward is having a more locally based focus for the future. I think will reap dividends. And secondly, having a whole system look at culture and seeing what we can do to shift that culture to be much more people-centred and community-centred. So that would be my response, Simon. Thank you.
Thank you, Ed. And Jim, you grab the microphone. Yeah. Oh, Michael. Sorry, Jim. Michael. So sorry. My fault.
Good morning. Michael, so Commissioner. A disturbing presentation, to say the least, I think. I'd love to commend you for your persistence over 10 years or more of actually bringing this to the attention. It would appear nationally, not only here locally. The thing that I'd like to know from you, I don't know whether you're going to need time to do this yet, but based on what you've been saying, it would appear, have we been using mortality to actually model or improve the health services we deliver, we could actually be delivering a much better health service generally, because the end product, which for all of us sadly is there, should indicate what we could have done to have actually had a better life. So my question is really, you said Sheffield apparently is doing a slightly better job. Are there any other health systems on the planet that actually take mortality as an indicator of what they should be improving for all of our people? Thank you.
Thanks, Michael. Do you want to respond to that, Emma?
Yeah, I think the system that we had, there's no reason why it shouldn't work, but any system is only as good as the people operating that system, recognising early when things are going wrong and acting. So I don't think I want to say more than that. I think what we said is we haven't looked at practice in any other trusts. We're not able to do that. We're not on the ground. Those communities need to be listened to. We looked at policies. So we found some policies that we think are slightly better, but not perfect. But again, we've got no evidence as to how those policies. But it's a better starting point. So yeah, we don't. It will be for the Sheffield communities to say whether the implementation of that policy is done any more safely or an impact. So I think we just don't know. But I think that's the thing. There's so many unknowns. We want people to be curious about the unknowns, and government have a role in that as well.
Okay, thank you. So, colleagues, let's see if we can move forward on this. I'm not going to rehearse that very wide and rich debate in full, but just some key words, I think, by way of summary. I think the board certainly was asked initially by Caroline to be restless, was the word you used. Actually, I think we, correct me if I'm wrong, but I think we want to be restless and curious and to continue that approach. So thank you, colleagues, in anticipation for that. It's important, I think we're recognising that going forward, that whatever the actions we agree and whether when we deal with the recommendations, that actually what happens makes impact and makes change, and that we also recognise there's a cultural change required, probably for us all, and actually continuously, as we continuously seek to improve. And we also recognise the importance of working together, both across disciplines and across geography, across trusts and providers and throughout the system, and in fact PAN system as well. So I think in summary we're saying as a board we want to make a difference, and we want to make sure going forward that services are fit for purpose. So with that very brief, I recognise, summary, let's go to the recommendations in the paper. There are 7. Lisa has already read them out, so in the interest of time I don't propose to read them out again. Is there any disagreement from board members in terms of accepting any one of those 7 recommendations? Are we content to accept all 7? Apart from the points that I made in the summary, are there any additional recommendations that colleagues would like to suggest? Tanya?
Will, I think it's just to kind of beef up what you're saying about the board, because there's nothing here about how we work as a board and how we hold ourselves to account and how we're critical friends. And I genuinely think that's missing. We've talked before about being an echo chamber and not necessarily challenging well. So I personally would like to, even if it's not in the recommendations, that we commit to it as a board and actually we make some action plan around that as to how we're going to do it.
Thanks, Tanya. Everybody content with that? And I don't see anybody saying no, but I saw Andy's hand raised at the back, so grabbing the microphone, over to you, Andy.
Thank you, Chair. Andy, actually, from Suffolk. There is one other thing that I brought up at the Norfolk and Woking ICB, and it was about the fact that it was unwise for the ICBs and NHS to commission this work originally last year, effectively behind closed doors. I think one of the things that we've learned from this today is where would we be now today had this been co-produced from the outset. So the learning is, or recommendation is, that if anything like this were to happen again, not just around mental health but elsewhere, let's try to co-produce it and not do so in the way that things have.
Thanks, Andy. So I'll take that as a suggestion for a commitment to co-production. And in addition, we have Tanya's additional recommendations. Everybody content that we amend appropriately? Agreed? All agreed? Thank you very much, everybody. Okay, so 10:20. We've overrun slightly. What I suggest, though, is that we take a short break now. Let's reconvene at 10:30 into the normal agenda, and could we also say thank you to all contributors today, of course, but particularly to Caroline and Emma, recognising the additional challenge that you faced incredibly well today and dealt with incredibly well. So thank you for that.
Thank you.
Okay, thanks all. 10-minute break. Thank you.
Thank you.
Recommence our meeting, and thank you for coming back promptly after the break. We are considerably behind, for good reason, I think, and thank you for the depth of that debate and the consideration that you gave to the item that we preceded this, if you like, normal business with. What it does mean, though, is that we'll have to motor on, otherwise we will start to lose people who've got other commitments, and we won't therefore treat agenda items properly if that happens. So let's go as fast as we reasonably can. With that in mind, item 5 on the agenda, minutes of the previous meetings. There are two, the 23rd of May and the 20th of June. Can I take those first of all for accuracy, and let's see if we can do both sets en bloc. Are there any comments, challenges or points of accuracy that anybody would like to raise for either set of minutes? Otherwise, is the board then content today to approve the drafts as presented, and do we resolve the 23rd of May draft and the 20th of June draft as a true and accurate record of those meetings? Agreed. Thank you very much. Matters arising and outstanding actions. Now, I think there are 3 which are not yet closed, but I'll give you a chance to correct me at the end, but let me go to those 3 first. First of all, 22. Amanda.
Thank you very much, Chair. So this matter regarding policies and future policy development is still ongoing. And may I suggest we actually defer or delegate that action to the People Committee, because that's the forum where we have previously discussed, and I think we could potentially close from the board and make sure it follows through from the People Committee.
So Amanda's suggesting work in progress and that we close from the board and delegate to the People Committee. I saw Tanya nodding. Everybody content with that update? Lovely, thank you. Let me go to Lisa for 57, please, Lisa.
Yes. There is a meeting arranged for August, but I haven't got any other updates.
So should we leave that on for future report?
Yeah.
And 60, Susanna.
Okay, so this is ongoing, but I mean it could be delegated to the Equalities Committee. We're currently strengthening the approach that we're taking to quality and health and equality impact assessments, and then what we would want to do is to revisit the existing quality and health and equality impact assessments based on that. So it's ongoing, or you could delegate it to the Equalities Committee if Laura were happy with that.
Everybody happy to close from this perspective and delegate to the Qualities Committee? Agreed, thank you very much. As far as I could tell, all the other actions and matters arising were closed. Does anybody disagree or have any questions with any of those closures? Everybody content? Agreed. And is everybody content that the matters arising log accurately captures the last 2 meetings, 23rd of May and 20th of June? So full and complete. Agreed. Thanks very much, everybody. Item 7, general update from the CEO. Over to you, Ed.
Thank you, Chair. So as with other recent updates, just to thank you for the whole system response to the industrial action. It's been a very busy month in July with junior doctors, consultants, and now radiographers at ESNEFT in industrial action, and the system has pulled together extremely well, as usual, to keep services safe and keep the show on the road. So thank you from me. Secondly, the NHS has published a long-term workforce plan, which is funded up until 2028. It's a very significant achievement and a very promising one. So I suggest that we have perhaps a board development session on the plan, as it's a very detailed plan, and understand its implications for us here in SNE and how we can capitalise on it. Thirdly, really pleased to say that SNE has been ranked number 1 nationally in terms of digital maturity. The first national assessment has been completed, and we rank first, which is excellent, jointly with Frimley. ICB. And I just wanted to recognise that that hasn't happened overnight. People like Dermot O'Reid and West Suffolk were very early innovators in this area, and I think we've reaped the benefits of their leadership. You know, a very proud achievement, and we really need to capitalise on it. Just wanted to say that we've been shortlisted for 2 Health Service Journal Awards nationally. Firstly, one around co-production in learning disability, which we might hear a little bit about later, and our children and young people's peripatetic crisis team, where we received an update at the board in previous months. So both excellent pieces of work being recognised. Susanna, no doubt, will talk about the expo that the Integrated Care system ran just recently, which was extremely well attended, very valuable use of time, excellent celebration of leadership really from all different sectors. So really grateful for all the hard work and organisation that went into that event. And then finally, just to pay tribute to 2 individuals who were recognised in the King's Honours. Firstly, Louis Horn from ESNEFT, who's the Deputy Associate Director of Nursing at ESNEFT, and also doing national work around race equality. And secondly, Professor Helen Langton, who's the Vice-Chancellor at the University of Suffolk, and she's been recognised for her services to education and healthcare. So thank you, Chair.
Thanks, Ed. Any questions for Ed? Richard?
And can we just say a huge well done to Ed in terms of also being given an OBE. It's a massive achievement for him and for the system. Well done, Ed.
Thank you, Richard. Thank you. Any other points or questions? Otherwise, let's move on then. Thank you, Ed. Over to item 8, improving access to dentistry. And Lizzie, I'm going to come to you for that in Howard's absence. Have you got a microphone there? Yeah, here it comes.
Thank you. So the COVID-19 pandemic had highlighted some of the issues in accessing NHS dental services, with many fewer dental treatments being delivered across Suffolk and North East Essex compared to the previous 2 years before. However, it is important to know that concerns regarding dental access predate the pandemic. Access to dental services is complex, and there are a multitude of challenges and barriers that influence the individual's ability to access dental care. It is important to recognise that no single approach will improve access for all, but routine dental care should be available to all who want or need it. Now, Suffolk and North East Essex are a particular pressure point, with 31% of our population unsuccessfully trying to get to a dental appointment in the last 2 years. That's 9% more in comparison to the rest of England. Now, many dentists in Suffolk and North East Essex have handed back their NHS contracts. Reasons cited for this include the level of remuneration, the level of activity delivered. Dentists have told us it costs them more to provide NHS service than they are paid for under the current 2006 contract, which is based on units of dental activity. On the 1st of April this year, Suffolk and North East Essex Integrated Care Board received delegated authority from NHS England for direct commissioning of dental services. This means we are now able to take commissioning decisions on behalf of our local population. Receiving delegated authority to commission and manage dental services enables us to have the flexibility to join up key pathways of care across our system, leading to better outcomes and experiences for our patients. For the past year, a number of key steps and decisions have been in preparation for the development of an innovative solution to address the dental crisis. So back in January this year, the ICB Executive Committee were presented with a set of options regarding commissioning of dental services to serve the population of Suffolk and North East Essex. The option selected was to commission the first stage of the solution to the dental crisis, by simultaneously increasing access to NHS dental treatment and increasing and upskilling the local dental workforce through education and training. The approval of this option provided authorisation for the development of a detailed service specification and some procurement options. The service specification outlines the services we want provided to our local population to address the inequity of access of NHS dentistry and to support local workforce development, with the overall aim of contributing towards our vision, which is routine and urgent dental care should be available to all who want or need it in Suffolk and North East Essex. The service will be available to the entire population of Suffolk and North East Essex, both adults and children. The provision will have 10 dental chairs, which offers 5,200 sessions a year, and that equates to just over 18,000 hours of appointments each year. This includes appointments during the week, evenings and weekends, and a proportion of these appointments will be made available for unscheduled urgent care for patients not currently undergoing a course of treatment within the service. These will be triaged through 111. A percentage of appointments will also be available for patients undertaking treatment for rheumatology, cardiology and oncology in our local acute hospitals, and those that reside in local care homes. The service will utilise the skills of the entire dental workforce. It will provide placements for newly qualified and in-training dental nurses, hygienists and therapists. On the 6th of March, the ICB Executive Committee approved the detailed service specification and the options to procure the service via a prior information notice or PIN. The PIN was published on the .gov portal on the 9th of March. This closed on the 31st of March 2023, running for 19 calendar days. In total, 3 organisations expressed an interest in providing the service. Following discussions with each of the organisations that expressed an interest, only one organisation confirmed that they would be able to deliver the service specification. Therefore, on the 18th of April, a veto notice was issued to notify all potential suppliers or providers of the ICB's intention to award the contract to the University of Suffolk Dental Community Interest Company. The veto notice was open to challenge for 10 days until the 28th of April, and no challenges were received. On the 12th of July, the ICB board approved the award of the SNE NHS Primary Care Dentistry Supporting Dental Workforce Training and Education contract to the University of Suffolk Dental Community Interest Company. Therefore, we will be using a personal dental services agreement contract to the University of Suffolk Dental Community Interest Company for provision of these services. The contract is not based on a typical UDA model, but on sessions. This focuses and provides a fair and equitable payment method and encourages the provider to focus on prevention as well as treatment. The service will look to go live in January next year. Now, as I mentioned at the beginning, no single approach to dental commissioning will improve access for all, but we hope that the award of this contract will make a real difference in our population being able to access NHS dentistry.
Lizzie, thank you very much. Any questions or points? Frida?
I think everyone knows the point I'm going to make, but I'd just like to make it again, Lizzie. I think you know what it is. That this is not equitable for North East Essex. There is no provision for North East Essex in this contract at all. It's based in central Ipswich, and none of my patients in tendering would travel to central Ipswich, so they continue to not have adequate dental services in North East Essex. I understand, though, from the meeting before that that there is plans to address this over the next 18 months. So I'd just like to ask how we can make sure that that is happening, and that in 18 months, which would take us to 2025, mid-2025, which is still a considerable length of time before Essex residents receive dental care in the same way as Ipswich Central is being offered, that how do we account that make sure that that's happening and not just put down that we've ticked a box on our dental services and this is as good as it's going to get, because it's not for North East Essex. Sorry, Lucy.
Okay, do you want to respond to that, Lizzie?
Yeah, thank you, Dr. Ratty. A good point raised, and thank you for raising it at the public board. The service that we speak about is open to all residents of Suffolk and North East Essex. So I just want to reiterate the point that no patients in our population are excluded from utilising the service. We do understand that Suffolk and North East Essex is a fairly wide region, and our population does span wider than just Ipswich and East Suffolk. We do have plans in place, as you mentioned, to improve access to NHS dentistry for our entire population. That includes the population of tendering as well. We would welcome the board to invite us back in 6 months' time to ask us to update on where we are with our NHS dentistry plans for the whole population. We would happily provide that presentation if we are invited back, but we will continue to update as we do regularly to the ICB Executive Committee. Thank you.
Okay, should we take that as an action? Agreed. 6-month update. Everybody content? Yeah. Any other questions? Otherwise, done. Thank you very much, Lizzie. Let's then move on to the North East Essex Alliance update. And Laura, over to you to introduce.
Thank you, Chair. I'd like to invite my colleague Ben Hughes, who's the Head of Wellbeing and Public Health based at Essex County Council, who'll be leading on the presentation today, which is around the approach around developing people-led approaches to health and wellbeing commissioning. So Ben, would you like to come up?
Yeah,
here?
Ben, I think you've been invited to Maddie's seat there.
Thanks, Maddie.
Okay. Okay, can you manage? And if you could press your mic button, that would be good. Excellent.
Thank you, Chair.
Okay.
As Laura mentioned, my name is Ben Hughes. I'm one of the heads of Wellbeing and Public Health at Essex County Council's Public Health team. I am also soon to be, formally, the Associate Director of Public Health for the North East Essex Alliance for 1 day a week, under agreement between Essex County Council and the Alliance. Today I wanted to present, it's actually quite timely after this morning's presentation, to be presenting today around what we're doing in Essex, around this particular agenda. The words co-production were mentioned a number of times this morning, and this is it writ large across the world that I lead on in Essex. So my portfolio includes substance misuse, health and justice, homelessness prevention, domestic abuse perpetrators, and complex needs, amongst others. So a fairly broad agenda. Oh, is it working? That will enable that has me looking at quite distinct and vulnerable groups. So we wanted to look at how we could make a change. There we go. To the way that substance misuse services were delivered across Essex. And this is just one example of co-production and one example of community empowerment. But it's an example that can be a number of care groups, I believe. We from the very beginning, we recognised that we need to put people at the heart of making decisions around what it is we are commissioning. Use the word commissioning in its broadest possible sense, which is not just buying things, but it is understanding need and making sure need is met. It is not just the process of procuring something. So we started from a position of creating a charity called the Essex Recovery Foundation. It's a charity incorporated organisation and has a board comprising people with lived and living experience. So that there are drug users in recovery and alcohol users. There are drug and alcohol users who are still in treatment. There are family members and carers on that board. And in fact, the Board of Trustees is chaired by a gentleman who graduated from our own drug and alcohol treatment system in Essex and went through the whole system and has now been in recovery for over 4 years. As I say, chaired by a man in recovery. His introduction to himself, not mine. We have a recovery advisory committee that is also chaired by a graduate of our own treatment system. And they are now jointly chairing the commissioning group across Essex around substance misuse. So they chair it in partnership with the public health team in Essex. And slowly but surely we are handing over chair of that completely to the charity. They commissioned our recent needs assessment. They drew up the specification, they monitored the progress, they supported the creation of the report, they've published it, and they are now developing the commissioning intentions from that. And they're taking a dynamic view of the needs assessment process, because historically we're very good at doing a needs assessment, sticking on a shelf, patting ourselves on the back and saying we've done that, now let's get on and do the job. No, that's the first bit of the job. So in their words, they wanted to take a really brave and radical view and approach to commissioning. So they drew up a 5-year strategic framework. We didn't do it. It was done by service users. It was written by the charity. And this is a direct extract from their 5-year strategic view. We're growing the recovery community, empowering people and their ideas, influencing life-changing services, and changing perceptions. Their words, not ours. So what was this brave and radical view they were going to take to commissioning? I'm happy to say that I think we've always taken a fairly radical view to commissioning, in that we look at it much more as a system development function rather than a purchasing function. But they have said that they want to transform the commissioning process and ensure that the recovery community are influencing and taking the key decisions needed to invest the resources we have available, but also to build and develop the system that sits around this community. And we will provide them with the support from the Essex County Council Public Health Team. So in effect, we are their commissioning support unit. We do their bidding. They're creating a new commissioning process that is led by the community. They're going to be transparent about the commissioning intentions and sharing those with the broader community from which those decisions are taken. They will award contracts based on evidence and community support. But they will ensure that all of those that are involved feel confident that their views are taken into consideration and they are empowered to participate in the process of commissioning. Thank you. But it is so much more, and I passionately believe co-production and involvement and engagement with the community has to be so much more than just engagement, consultation and involvement. Historically, in the drug and alcohol world, we've used those 3 words interchangeably, and ultimately what we've done is we've employed a tokenistic approach to engaging with communities. We've had a member of the community sat on the board. We have a drug user we used to have drug users sat on the drug and alcohol board. This is where we've taken the next step, and we've absolutely committed to transferring the responsibility, control and power to the community to lead on the design and co-design of the system with the support from Essex County Council Public Health, but in partnership with all of the other key stakeholders. And this is going on across the whole of Essex, but we are, for the purposes of this presentation, we're focusing a lot of the effort in North East Essex because it is where our biggest area of need and demand is. But we're also embedding the lessons that we've learned from the process of doing this into future commissioning and developing future commissioning models. As part of the public health team in Essex, we have a communities arm, a communities element, and we believe that this has got to be how we do this. We've got to collaborate. It's got to be place-based. It's got to involve the whole system and the whole systems approach. The needs of drug users, for instance, are not simply those of prescribing and psychosocial interventions. They are housing, employment, education, training, transport, access, all of the plethora of issues that involve us all. And we are turning these principles into practice and enabling the voice of communities in everything we do, seeking to include and engage wherever we can, but most importantly then looking at opportunities to devolve that power to the community. And we're trying to embed this as a way of working across the North East Essex Alliance. In particular in the arena that I'm leading on around drugs and alcohol, but also moving that out to broader agendas that impact on the community and looking at opportunities to empower communities to take far more control over the issues that affect their lives. And by sharing, so we have Essex Recovery Foundation community leads working with others across the Alliance. They're sharing their experiences of co-production and thereby infecting, as it were, the broader community. Building the capacity of the lived and living experience to actually involve themselves in the agenda that impacts on their life. We heard this morning about the work that was done in the report that was produced. And so developing services by and for the community.
Is that it?
That's me.
That's done? Okay. Laura, did you want to add anything by way of conclusion before we open up to the board?
Thank you, and thank you, Ben. I think it gives a good demonstration of how we can truly work with our communities and make sure that we hear their voices around their need. I think this is vitally important, not just in North East Essex, but there's learning that we can take across all of the ICB services. I think this is a truly innovative approach. It's been recognised by the Essex Health and Wellbeing Board as being so. In fact, I think it's being recognised nationally as well, and I think we're very lucky to be able to have the experiences and support from the public health team to have been able to broaden this into the things that we do and take forward. So thank you.
Okay, thank you both. So, board members, Lisa first.
Thank you, Ben. It would be great if we could kind of capture that on something that would be really easy to share across the system as a model of good practice. It really aligns with the Hammersmith and Fulham model that we know that the campaign that work with NSFT are very supportive of. I just wondered, does it interface at all with the anchor organisation model around employment and how we can support people to get work within health and care and... Or could it, maybe? Maybe the better question is, could it?
I think it's applicable, and I think, when I presented this previously at the ICS event, I think what I was suggesting was that we've gone all the way and created a charity, we've handed over control of the resources, we've handed over control of the commissioning agenda. I think there's a spectrum of approaches, depending on the environment within which you're operating, and I think it just so happens that within this environment, this was the chosen and preferred approach, but I think I don't think the nuclear option is the only option.
Yeah.
I think it's
and also perhaps recognising that this is a journey.
Yes.
And this isn't the end of the journey, so supportive of that. I think board generally very supportive of that approach. Yeah. Okay. Thank you very much, Ed.
Yeah, Ben, you're absolutely brilliant, aren't you? There's no doubt about that. Similar comment about whether perhaps you could help us within the ICB in terms of commissioning teams and the kind of philosophy that we need to learn from here, and also whether there's something across the system. We did a lot of work on co-production already, but this is another great. It's an inspirational example, isn't it? That it's transferable. So if you would be willing to work with us more broadly, that would be great.
Sounds very happy to.
We're taking that as a yes, so thanks, Ben. And based in lived experience as well, Ed, which is great. Susanna and then Richard. Susanna?
Just building on Lisa's comment, so Ben was the star turn at our recent System Leaders Away Day, looking at system pressures, where you shared this case study. We've written it up, Lisa, so if you want, I'll chop out that specific page so you can share that more widely. But it is a really good example. I think the point about anchors is about what thinking differently really means, because we just throw around lots of terms about anchors and co-production and commissioning, but it's about just rethinking really and thinking very differently. And I think it would be great, Ed, if we could bring some of that more into the ICB.
I think for me, culturally, it's about ceding control as well, and that's always a difficult one for us who have power, perceived power It's that ability to hand over that power.
And trust and culture.
And trust the
It's
community.
culture, isn't it? Yeah.
And with a slightly challenging cohort as well with drug and alcohol users.
Yeah. And that's not to say it will never go wrong, but then what do we do about it? Okay, thank you, Richard.
So I think this is really exciting, could be a really big feature of how we approach our commissioning moving forward. If we're brave and if we're willing to take risk in terms of letting go. We're doing a little bit of this in mental health with some of the smaller partners that we're working with, but again, I think we could go much further. We're in the process, Paul and I and colleagues are reviewing our commissioning policy as an organisation, so we'll be bringing that through executive and through to the board in due course. And I think there's an opportunity to influence that, Ben, in terms of what that policy says and some of the options that we could put in there when we're looking to make commissioning decisions. So I'll share with you offline. It'd be good to have a chat. Thank you.
Okay. So, Ben, Laura, thank you very much. I think as a board, we're obviously receiving and noting as requested, but we're also supportive and recognising that this is not the end of a journey, but we want to see it go further, faster, deeper, and part of our cultural change. Everybody content? And thank you very much. Thanks, Ben. Thank you. Okay, in which case then moving to the next item, the All-Age Autism Outreach Service. I think, Lisa, you're going to say a few words before handing over.
Thank you. I'm just going to introduce you to George, actually, another colleague from Essex County Council, who is the author of the paper, who'll be able to talk about it much better than I can.
Great, thank you, Lisa. Yeah, hi everyone, I'm George Martin. I'm a Commissioner in the Learning Disabilities and Autism Health Qualities team at ECC. So we work on behalf of the 3 ICBs and local authorities that cover South and Essex and Suffolk. So today we're just asking for approval to carry out some market engagement ahead of the future commissioning of this all-age autism outreach service. So across South and Essex and Suffolk, a key deficit reported by autistic people and their families is that community services do not understand the impact of their autism on how they experience the world or how they process information. And whilst there are various services in place for individuals with learning disabilities, autistic individuals are not supported well by the local health and social care system, often leading to avoidable admissions into inpatient mental health services and poor outcomes for autistic people and their families. A project team has been established to oversee the development of this service, and engagement with individuals and families with lived experience has begun to inform the service design. The service will be available across the entire Transforming Care Partnership of South and Essex and Suffolk, and will support those autistic people without a learning disability who are most at risk of admission to a mental health hospital. There's no immediate request for funding for the service. Funding has been secured from a service development fund from a medium-term plan for an initial 4-year contract. During the lifetime of the contract, evidence and options for funding will be brought to the LD Health Qualities Board for members of the collaborative partnership to consider future funding beyond the life of the initial 4-year contract. Contract finance and procurement support for the commissioning of the service will come from MSC ICB. As this is a relatively niche service, we're keen to engage the market as early as possible to inform them of our intentions, allow time for potential partnerships to be discussed and to receive feedback from the market on alternatives that we might not have considered. And we plan to come back to each ICB in September to request approval to run the procurement exercise for the service once we've clearly defined that spec and had that engagement and feedback from the market. Thank you.
Okay, that was nice and sweet, short and sweet. Thank you, George. Perhaps I could ask the question, does anybody think there is a reason why we shouldn't engage the provider market ahead of future procurement? And I don't see anybody keen to say they don't think we should, so can we, any questions? Otherwise we'll take it as agreed. Engagement with the provider market agreed. Done? Okay, lovely. Thank you very much. Okay, excellent. Thanks very much, Lisa and George. In which case, on to item 11, improving uptake, experience and outcomes of learning disability annual health checks. Ed.
Thank you. I think it's hopefully quite a straightforward paper. We're asking the board going forward just to prioritise our time to really focus on this metric for annual health checks and action plans for people with a learning disability. Why would this be important? I think the why is quite obvious in the paper. Only 37% percent of people with a learning disability live beyond the age of 65, compared to 85% in the general population. So it's a huge health inequality, possibly the most stark, I think, that we would have in our system. This paper is not saying or suggesting that we haven't prioritised this in the past. We delivered 82% in terms of annual health checks in the last year, which is a 10% improvement on the previous year and is significantly above the national standard of 75%. But the issue is a bit deeper than that, because you can hit a percentage, but what about the quality of the conversations? What about the quality of the process? What about the action plans? If there isn't an action plan for the individual, their family, on the back of the health check, it's not meaningful. So it's really about looking at the whole picture here, from the patient experience, the client experience, through to the workforce development and the quality of the entire process. So I'm confident we're heading in the right direction, but given this is this cohort has probably our biggest health inequality, why not push it much further? Because we talk about, the standard of 75% being delivered, but what about the other 25% that don't receive that health check or that action plan? So I'm sponsoring this across the east of England, as well as working with Lisa and her brilliant team locally to continue the momentum. Thank you.
Thank you, Ed. So, any questions, points on Nick?
Thanks, Ed. Really welcome the paper. I suppose my question is the other points that you made there around addressing the other areas of inequality for this patient group. So, for example, LD patients, the only one that we would prioritise without looking at clinical priority. They go to the top of our waiting list effectively. I'm just wondering where else we pick up those other inequalities and where we're addressing them, because there will be a whole range both in primary mental health, secondary care.
Yes, sure, yes. So we have in Suffolk, we have an LD Health Inequalities Partnership Board, which it would be great. You should, but it would be great. It would be great if you could encourage attendance from SNF. That would be amazing. We are looking at the moment, the dashboard that we report isn't where we need it to be. So the data that flows from SNF down West Suffolk actually would be great, and your sponsorship of that would be brilliant. Thank you.
I'll take that away and pick it up.
That'd be great action, Nick. Thank you very much. Yeah, no, we'll note that. Thank you. I'll go Maddie and then Richard. Maddie.
Thank you, and thanks, Ed. I also agree. I think we have made progress, and a great deal of that progress is due to the partnership that we've had with East Anglia in terms of supporting with engagement and outreach and education and training to us all. Lisa's got a furrowed brow. I did get that right, didn't I?
It's just something I want to pick up.
Oh, okay.
I'm looking at you, furrowed. Something that myself furrowed.
So I really want to just acknowledge how important that partnership is in enabling people to access their health checks and providing that education to us all and to primary care. I've been thinking about Ed's challenge around the quality, and I think there is an opportunity for kind of peer review with the organisations and between primary care organisations and partnerships as well, to see how we can take that next step, because we need to be at 100%, not just 75%. Thank you.
Sounds good. Let me just come to you with your worried furrowed
With
brow.
my furrowed brow, only because I talked about the partnership board in Suffolk, but of course we have an amazing LD Health, sorry Pete and sorry George, of which Pete and George are amazing members of, and actually are probably a bit further ahead than the partnership arrangements that we have in Suffolk. So I just wanted to make sure I brought that. Thank you.
We'll make sure we note that. Okay, thank you. And Richard?
Mine's just a practical point around the JFP, dare I say. We didn't include this as one of our 22 key indicators, so I think if the board agrees today that this is a key priority, we'll add that as a 23rd against the requisite part, because otherwise it doesn't align if we've said the board's going to focus on these and then we've agreed that one, we need to make sure it's consistent.
That'll be a good action, Richard. Thank you. Yes, and lots of nods around the table there. So Pete, yeah, come in.
Yeah, I think we do need to make sure that we focus this on it as a system, and that we go beyond the kind of the chasing the target to understand what the purpose of this is ultimately. So I think, yes, it's about the annual health checks, but it's also about the delivery of the health action plans that follow through from that. And it does feel to me that we really need to be making the connection between shared care records, visibility across health and care about actually the delivery of those action plans, so that actually it results in real change and proper impact for people, which will extend life. So I suppose I just want to make sure that we centre the focus of this beyond the target itself and really kind of go back to the purpose.
Yeah, and general nods around the table there. One last one from Susanna, and then we'll see if we can agree the recommendations.
So on that point, absolutely right. I mean, it's all about the improving health outcomes, which there's huge inequalities around. So it is absolutely part of our integrated care strategy. We're measuring the metrics around that. We're just strengthening that section. There'll be a whole section around inequalities around people with learning disability with a load of metrics attached to it.
Great. Okay. So, colleagues, 3 recommendations in the paper. In short, we're asked to accept that this is vitally important and that it's a key metric for us going forward, and that also we take the progress reports as quarterly reports at this board on the action plan during 23-24. Everybody content with those recommendations? Accepted? Agreed. Thanks very much, everybody. Thank you. ICP update, Susanna.
Okay, so I've provided a short update report, which you have. I'm just going to focus on 3 areas of work for the ICP in particular over the last couple of months. So the first is that I mentioned earlier on that in May, around about 70 leaders from across the Suffolk and North East Essex integrated care system took part in an away day, system learning away day, looking at what we could learn from the period of significant pressure on the system over the winter 2022-23. It really was a very rich agenda, I think overwhelmingly so. It included an enormous amount of data. Huge thanks to colleagues in public health in particular for drawing together and helping, I think, everybody better understand what had happened, I suppose, in terms of the complexity of what had happened over the winter, but also to all of those who shared excellent ideas for what we can do differently, how we can think differently, and what we need to do differently going forward. That is now the important part. So we have produced a written report of that event and circulated it very smartly after the event took place. And we'll be following that up at the ICP at the meeting actually in September, which will be an in-person workshop in West Suffolk. So that's been an important piece of work, and as I said earlier on, it included the work that Ben Hughes presented just a few moments ago. Next up, Ed's already mentioned our annual whole system expo event, which took place on the 7th of July at Worsted Park. This is an opportunity to do what we're reminded by Caroline and Emma was important to do, which is to really try and unleash that creativity, get the barriers down, develop the relationships and all of that work around partnership and the broader whole system that's so important. So the event was incredibly well attended, and it included a very large number of contributions across particular focused areas like lived experience. So thanks to the Integrated Care Academy at the University of Suffolk for helping to lead that. A very busy community zone with partners from across our voluntary community, faith and social enterprise sector. For the first time, a social care zone, which was included in particular social care, independent social care providers, heritage and culture, and also research and innovation, and the research and innovation zone with the Eastern Academic Health Science Network, and also ESNEFT were very key to helping us to pull that together. And also on the agenda, I think we have a number of challenges. So alongside the Health Minister, Will Quince, who of course is the MP for Colchester presenting, we had a presentation, a very powerful presentation from Paulette Lewis, MBE. She's the president of the Caribbean Nurses and Midwives Association. And of course the event took place just shortly after the anniversary of Windrush. I think it's fair to say that Paulette has challenged us as a system to be better, to do better, and to really look at how we can better support particularly overseas staff, and to make sure that by next year the faces in the room, the voices in the room look different to how they do at the moment. Lastly, I just want to mention our ICS Voluntary Community Faith and Social Enterprise Resilience Charter. This was approved by the ICB in June. This is the culmination of work across not just voluntary community, faith, social enterprise partners, but also statutory sector partners across the NHS and local government coming together to agree a shared vision for how we can build and ensure a much more resilient voluntary community sector. So there were over 100 people took part in the work to develop the charter, and it was officially signed at Expo, which is really important because that's that real formal kind of commitment towards working together and doing things differently together as a system going forward. So those are just some highlights. The next meeting of the ICP, for those who are interested, will be online in August. It's on our website, followed by an in-person event in September in West Suffolk in Bury St Edmunds. Thank you.
Thanks, Susanna, and I think we all agree as well the Expo event was a great event. Well done to you and the team. A phenomenal amount of work, of course, goes into these things. They don't happen on their own, so thank you to you and all for that. And certainly everybody who's spoken to me has said we've got to do it again, so don't hold your breath, as it were. Okay, any questions for Susanna? Otherwise, received and noted. Did you?
Sorry, I was just saying how wonderful seated yoga was. I was sitting.
Oh, I missed the yoga. I mean, that was one of the challenges. You actually getting around everything, wasn't it? It was, yeah. Anyway, everybody content? Great. Thanks very much. In which case, let's move on then to the finance report. Chris, you're deputising for Howard today, so over to you.
Yep. Thank you all. So the report within the papers is for month 2 and was presented and reviewed by the Finance Committee on the 11th of July. So it's a report in 2 parts, one with regards to the Integrated Care Board itself and the second with regard to system partners which form part of our overall financial accountability to NHS England, namely ESNEF to West Suffolk FT, the Ambulance Trust and the Integrated Care Board. So you'll see within there, obviously it was relatively early in terms of reporting for the financial year. At month 2, there's a summary of key financial metrics within there for the Integrated Care Board, all reporting on plan. In terms of some key points to note for the Integrated Care Board, one is emerging pressures with regards to out of trust placements in North East Essex for mental health, and growing pressures further within Suffolk as well, which we'll review at this point in the year to see if there's any particular reason and driver for that, and anything we can do to reduce the overspend in those areas. As of month 2, there was no national data available for prescribing, which would be a key risk area throughout the financial year due to the over the last 12 months being a pattern of unavailability of drug supply, etc., which means increased pricing, etc. So as of month 1, the data has now finally arrived, and that showed that we were broadly on plan, which was welcomed and has not been the case throughout most of the rest of the region. So that was welcome news. The other key risk area is continuing healthcare, and the outcomes of negotiations with a number of providers still not yet concluded, so we will expect to see increased costs when those happen later on in August, when we expect to have a much clearer position on there. So still early days in terms of the financial position, and month 3 when you look at it will come through and showing on plan. There's also separate information in there with regards to the financial position of those budgets delegated to committees. You can see that on track at this point in time, but obviously in terms of particularly the North East Essex Alliance Committee and the Suffolk Mental Health Collaborative will see pressures in terms of their budgets, in terms of those placement costs throughout the next couple of months. In terms of the overall efficiency delivery position for the ICB, reported off track as of the first point in reporting is a lack of availability, so we really want to make sure we're seeing evidence of delivery and not assuming delivery in this financial year, but reporting that we will still continue to meet the overall target and also continue to meet the running costs limit target and the mental health investment standard as well within there. So in terms of the kind of the system position, so at month 2 the system was £300,000 off plan. That deteriorated further to 2.3 million in the month 3 figures, and not contained yet within the pack, the timing of the board meeting. This was predominantly driven by the position at West Suffolk FT, noting pressures in terms of efficiency under delivery, additional costs in relation to industrial action, additional ward costs, and pressures from the shortfall in funding from the National Pay Award in particular. And it's important to note that month 2, in particular, efficiency delivery for all organisations is an issue which all organisations are seeking to address. Also contained within the pack was an overall financial self-assessment undertaken at month 2. It's important to note that obviously we are expected to take internal action as a system as part of the new regime, that we would address our own financial issues. So important to kind of have that assessment and figure out where we are. The report kind of highlighted 2 areas really. One, the need is for all organisations in the system to address recurrent efficiency delivery to improve the underlying deficit within the system, and in particular for West Suffolk worsening in-year position and increasing the significant underlying deficit at West Suffolk of over 30 million, which is now at 8% of turnover. And the Trust has obviously recognised the need to act quickly and decisively on this, so rapidly developing a recovery plan with the first draft due this week, which will outline the scale of the issue, actions to be taken to close the gap, and changes in kind of infrastructure and resources required to deliver. The Trust will have an internal financial recovery group which starts this week. And obviously progress is being made throughout the system to identify capacity to support the Trust. So it's important to note we do have a limited window to kind of address this issue ourselves before we can expect further regulatory action if we fail to do so. But we do have a window of opportunity to put the right things in place to support the organisation in improving its financial position, with a note of caution that obviously still early days for everyone at this point, and everyone also needs to focus on delivery of efficiency, etc., as well as all of the other competing requirements at this point in the year with industrial action. But yeah, that's it. Thank you.
Okay. So quick summary before I come to Craig for comments from a West Suffolk point of view. But would it be fair to summarise, Chris, by saying month 2 as presented, not too bad, but month 3 deteriorated, and it's getting hard out there, but there is for West Suffolk particularly a financial recovery plan and financial recovery group in place. So with that, Craig, over to you.
Thank you. To be honest, there's not a huge amount I would add to what Chris has said. That is almost word for word the presentation I gave our board on Friday, and does reflect, I think, the consistency of approach across the ICS. I think the finance community has always worked well together and continues to do that and face the challenges together. There are 2 tracks that are going on within the organisation, as Chris has described. One is around dealing with those internally generated pressures around under-delivery of our cost improvement programme, which is reflected both in the position this year and the recurrent position that we're presenting in future years. And then there is a separate piece of work that is going on around addressing some of those drivers of the financial underperformance, so industrial action, pay award, and so on. Some of that may find a national solution, but there's still a lot more detail to work through on that. But happy to answer any questions, but Chris has presented effectively for West Suffolk.
Okay, thank you, Craig. Any questions? Otherwise, we're asked to receive and note the report and indeed Chris's and Craig's updates. And I think I'll go to Ed in a second, but I think we're going to be looking for an update on this, of course, at the next board meeting. Ed?
It's just a slightly separate separate point. On your first slide, you've got the pie chart of how the money from the ICB is divvied up within the different areas of the system. So it would be a good exercise at some stage to have a look at that, because ideally you'd want the 52% in the acute to reduce and the primary care, community care, mental health, continuing care potentially to increase. So it's just thinking about the financial strategy over time. This is medium term rather than short term. But if we're going to really meet the demand challenge we've got to move some of those percentages in a managed way.
Okay, thanks, Ed. And I noted a number of nods around the table as you were saying that, so we'll take that as a future action, Chris, over in your area, but actually it's all system partners, isn't it? So we'll leave that one with you. Any other questions or points? Otherwise, we're asked to receive and note, with the additional comments, of course, an update for currency with regard to time. Agreed? Good. Thanks very much. In which case, item 14, the Integrated Care Performance Report. I'm going to go to you, Paul.
Thank you.
All yours.
In the interest of time, I will take the report as read, but to raise a few issues, if I may, Chair.
Yeah.
I think I'll point to the System Oversight Assurance Committee activities. You will note that the performance reviewed at that committee, and nothing was chosen to be escalated. But I would point out a few things. Certainly in terms of escalation at the meeting, there was a discussion around mortality, regulatory assessment, and any performance and patient safety, which was raised by the Quality Committee, which was discussed. I would also point to outpatient transformation, which now is a key strategy for us moving forward in terms of the waiting list growth. And there's been an agreement that we should have a system-wide group to start focusing on this and accelerate, move quicker and faster to manage our waiting list going forward. And finally, Ed has already mentioned industrial action. We had a conversation around assurance, I guess, whether we were ready to meet the challenges of the industrial action. As an output of that, I actually asked my team to start developing a dashboard which tells us what the impact was likely to be. And whilst I wouldn't want the numbers to be fully quoted until they are fully finalised, it's interesting to see we've had 23 days worth of strike action up until the 17th of July. At least 6,900 shifts have been lost as a consequence of that, not counting, as I said, the recent consultant and radiographer strike action. And we've lost something like over 13,000 procedures, outpatients, and elective activity. That has to have a significant impact moving forward in terms of access. And I think we need to start to understand that as a system. There are some health inequality issues, I suspect, within that conversation as well. So once we've sort of sorted out the dashboard, gives a bit of an insight, I'd be happy to share with relevant committees in terms of what we might be able to do about that. But it is quite a significant impact. And at this point, I would like to really thank all the operational and clinical teams who have been planning for this, which has been significant amount of continual planning. And as I said, we're in our third consecutive week of a strike action, which has been a really significant impact on operational staff and clinical staff alike and ICB teams to actually manage and plan for this. So I'd like to make the point at this moment in time. In terms of the points of note, we received a letter from Claire Panic, who is our regional director at NHS England, who essentially reminded us what our priorities were in terms of the forthcoming, the remaining part of this year. And broadly speaking, you'll see within the document, it talks about recovery of our core services and gives quite a long list of the things we should be focused on. And you will see that is pretty much the things we already cited as a board going forward. It talks about setting our ambition to deliver NHS long-term plan, and we've already talked extensively about GIFP, and it also talks about transformation, and we've heard many good examples of that going forward. So Claire Panic wanted the board to be cited, so essentially this is what this does. And my apologies, I've noticed the letter wasn't circulated, and we'll circulate that after this meeting, people to see the detail of the letter going forward. Finally, the other thing to pull out really is we're rapidly approaching the conclusion for our annual assessment. We understand it will take form of a letter, which will be addressed to you, Chair, in terms of the final conclusion for the year. It will essentially approach the assessment in three ways. It will look in our annual report and our accounts. It will look at the routine interaction we've been having with NHS England going forward through committees, quarterly performance review, which have been heavily trailed at this board in previous months. And then finally, it will seek to understand feedback from key system partners. And we do have a meeting with our regional colleagues tomorrow to go through some of those conversations going forward. So again, an end-of-year assessment is pretty imminent. And then the only other thing I would like to rectify is that within the report, it's still said that West Suffolk is not reporting any target. You have been, and you are far exceeding trajectories as it is, and supporting the system really, really well. So thank you for that, and I'll make sure the correction is made in future reports. That's it, Chair.
Thanks, Paul, and that latter point noted. Thank you. And thanks for a huge amount of information in this report and for all the work that goes into it. But of course also delivering the metrics. And we mustn't forget, we were reminded, weren't we, this morning by Caroline and Emma, and we mustn't forget that actually it's the impact of the delivering these services on the people, on our people that matter. And so we need to aim for the best possible services that we possibly can for the benefit of our population. So thank you for all that work. Any questions for Paul or colleagues? Otherwise, we're asked to receive a note with the additional comments from Paul. Noted? Lovely. Thanks very much. Thank you, Paul. Next item, the Bath Board Assurance Framework in two parts, I think. Amanda,
Indeed.
over to you.
Thank you very much, Chair. So if I take the former first, so here we have our updated Board Assurance Framework, which is up to date as at July of this year. And as we can see, we have 10 current live strategic risks that continually are reviewed and updated and overseen by the Executive Committee on behalf of the Board. That Board Assurance Framework is also discussed with the Audit Committee at regular meetings. So taking the recent Board Development Workshop we had back in April and the subsequent meeting conversations we've had as a Board, we have taken all of the feedback into account and have tried to really revamp, refresh, modernise our current Board Assurance Framework and incorporate the partnership, which indeed was a comment previously raised as well. So we're trying to connect the board with the partnership, and we're also wanting to try and take into account any board opportunities going forward, which was indeed a comment and a challenge I think Andy Yacoub raised at the January board. So we will see opportunity reflected in an updated Board Assurance Framework version 2. This is not the final document, but hopefully board colleagues will see it's very different to the current BAF rather. We think it's much more easy to understand. It's, we think, easier to read and more accessible to members of the public because indeed our Board Assurance Framework is public facing. So to attempt to illustrate what a new updated framework might look like, we've taken just one risk, and that's the workforce risk, and tried to overlay it in an updated framework which we can see. And if the board indeed likes the look and the feel thus far of what's presented here today, I would be recommending that we actually, going forward for our September board, look to incorporate our current risks into the updated framework for further presentation. And of course, it will be presented to our Audit Committee as well going forward. But I think the last final point I would like to make, we are really underpinning the risks and actually linking in and drawing in the anchors dashboard information that Susanna and her team are working through as well. So we're truly trying to connect the partnership with the board as we move forward. So I leave it there, Chair, but hopefully board colleagues will like the attempted updated version, but very happy to take any questions.
Thank you, Amanda.
Thank you.
Ed?
Thanks, Amanda. I'm just conscious of the comment from Caroline and Emma around mortality, which I don't think I can see on our BAF at the moment. So maybe, assuming colleagues are comfortable with that, we should introduce that perhaps talking to a Norfolk and Waverley ICB, so some consistency.
Colleagues content? Agreed? So with that amendment, and we're asked to then approve today's BAF, should I say, on the existing format and as presented. So let's do it in two parts. This is part A. Today's BAF approved. Done. And then the future BAF format as amended. And no doubt, Amanda, that's a live document that you'll be working through that'll come to the September board in, if you like, a revised draft format. So we'll get a chance to look at it and comment again on the whole. Is everybody content with that way forward? Agreed? Lovely. Thanks very much. Thanks, Amanda. In which case, item 16, the pharmacy, optometry and dentistry highlights. Maddie.
Thank you very much, Chair. So you asked if post-transfer of the delegation of these services and the stabilisation of the basic processes associated with that, if some more strategic reports could be brought to the board. And so this is the first. Obviously, today we heard about the major developments in terms of our dental services. And there's two other important points which complement that within the report in terms of dental. One is in relation to oral health more broadly and the work that we need to do and to invest in to support the best possible overall oral health. And secondly is in terms of the work that we need to do in terms of orthodontic waiting lists. So there are two other areas in terms of dental which I would like to bring to your attention. In terms of pharmacy, noted within this report is a submission that we have made nationally in terms of the forward plan for pharmacy services. And we will bring back a more holistic report about pharmacy services, which will combine the work that's going on nationally to look at the contract and the challenges as well as the opportunities which our pharmacy colleagues face with the action that we're taking locally. So that will be in September. And thirdly, just to flag in terms of optometry, there are two important developments in terms of minor eye care, urgent community services and the re-procurement associated with that, and with hydroxychloroquine retinal screening, just to note as well. So we would envisage that we'll bring back further detailed reports on all of them. This is an overview to supplement the detailed dental report brought to you. We look forward on the 29th of August to welcoming our colleagues from optometry, pharmacy and dental to our currently medical-only primary care commissioning group, and we will meet in common across SNE to have that first meeting. Last but not least, with the kind of transition complete, I'm really pleased to hand over to Peter as the sponsor director for POD going forward. So happy to take any questions. Thank you.
Thanks, Maddie. So any questions for Maddie on that brief update? Otherwise, we're asked to receive and note, and also note, Maddie, that you're going to bring back a strategic briefing on pharmacy to the September board. Or Peter will, sorry, I beg your pardon. Now that you've given him that sideways pass. Yeah, excellent. Agreed? Lovely. Thanks very much, everybody. So item 17, Amanda, I'm coming back to you for the year-in review of the Constitution.
Thank you very much, Chair. So here we have our current constitution, which is indeed just over 1 year old. Now, 6 months ago, we actually agreed as a board to review and make sure it was fit for purpose. At the time of that review earlier on this year, we actually confirmed that there were no further changes to be made. However, in recent months, we have actually had to amend our constitution to reflect our non-executive member numbers, and we know that they have recently increased from 3 to 4. And in doing so, that required our constitution to be updated, which we saw at a previous board meeting. And indeed, from that board meeting, we then had to send our updated constitution to NHS England, because we know that this is a statutory document, and ultimately any changes required do need to have their approval. I'm pleased to confirm that when we actually presented, they did actually support our additional changes to reflect for non-executive members, and that was approved in June. Since that approval, we have now published it on our website. So the purpose of today is really to invite the board, from the review that we've undertaken and from the recent updates, are there any further changes we would wish to make to our membership as we move forward? Thank you, Chair.
Okay, thank you very much. And Amanda, could I ask you, before board members come in, do you think that we've got the membership right, or is it worth a considered review of the membership?
Thank you very much for that question, Chair. So I think it's fair to say that our constitution should never be perfect, and we should never be complacent on what we have produced. And I would like to think there is always opportunity to review and to reflect and indeed improve if there is appropriate opportunity and the like. We mustn't forget, though, that there are strict guidance rules in place because it is a statutory document, but I think we do have opportunity to perhaps consider the membership and indeed any observers that are missing. And just some examples: where is the voice of the higher education, further education, and indeed, given our specialist delegation that we took on from NHS England this April, where is the voice of podiatry, optometrists and dentists going forward? So potentially, Chair, there is opportunity to further review, and it may well be that we do undertake a review and perhaps revisit as a board in maybe 6 months' time.
Okay, that's your suggestion, and we'll see if board members comment on that, negatively or positively. But Ed, over to you.
Yeah, it makes sense to me. We've had a direct question around representation of the dental sector, questions around higher education. So I think we can't leave them hanging. We need to view them in the round as a board and make a decision.
Okay. So suggestion is, and would the time frame work for you as well, Ed, if we asked for this to be done and then that review to be undertaken and then brought back formally to the board in 6 months' time? It may well be, of course, that we get an interim update as that work is progressing. That would be helpful. Tanya?
Just thinking about that, can we also think about the size of the board? I don't know how we compare to other boards, but it feels quite large. So when you're trying to have diversity of discussion around the table, it gets harder with more and more people, but it's that real challenge between the quality and the mix on the board and the size to make it manageable. And maybe just thinking as well about the membership of the committees, especially now with 4 NEMs, can we just kind of re-look at the division of responsibilities there as well? Yeah, so balance, size, diversity, access, debate, maybe a little benchmarking as well with others, and then reflecting also into committee memberships. So thank you. Susanna?
Just that it would seem sensible to look at that alongside the membership and the role of the ICP as well, because obviously that has a very wide membership indeed and works slightly differently. But the two things, I think we're beginning to learn how to I always describe it as driving the car, that use the two effectively alongside one another.
Yeah, of course, the ICP is at about 70 now, isn't it, approximately?
It is, but we have, to be honest, different ways of engaging. So sometimes the ICP can be very, very broad in terms of, it meeting and discussing things. It's just really about making sure that we have ways in which people can contribute voice in the right places. I think that's the point.
Okay, good. So, noting the current position and the update that we agreed over the current review period, and then agreeing those further actions over membership size, diversity, and so on and so forth. All agreed? Interim report perhaps in 3 months, Amanda, approximately, and then targeting a 6-month formal approval of any changes.
Thank you.
Agreed? Lovely, thanks very much. In which case, then, let's go on to terms of reference. I'm sticking with you, Amanda, for the Remuneration and HR Committee and the Finance Committee, but I'm hoping that we'll assume that colleagues have read the terms of reference. Is there anything you wanted to highlight, or should we go straight for approval?
I think we could go straight for approval. The comments are shown for ears in red, so great, thank you.
Track changes there, aren't there? Any queries? So there's two sets, A, Remuneration and HR Committee, B, the Finance Committee. Any comments, good or bad? No comments. Everybody happy to approve as presented? Approved? Lovely, thanks very much. And then, sticking with terms of reference, the Health Inequalities and Prevention Committee. Laura, do you fancy doing it the same way? Anything you'd like to say by way of intro?
Just to note, this is obviously a new committee delegated from this board. I think there's a recognition from discussion around these terms of reference that we need to be iterative in our approach over the next year. The only outstanding point to note would be that I don't think we've discussed the frequency of reporting back to this board as yet. Our next meeting is in September, and then our subsequent meeting is November.
Yeah, so there's a question of timing there,
Yeah,
isn't there?
there is.
So I think all we can do there at the moment is note that.
Absolutely, and then we can
Yeah.
discuss further when it would be appropriate to come back to this board for an update.
Okay. It'd be useful to get something in this year, wouldn't it? Should we take that as an action to be worked on?
I can work on that with Stuart Keeble, who's the chair of that group, if people are happy for me to do so, and then I can feed back to Joe about timing.
Okay. Happy with that? Everybody content, Paul?
Just wonder whether there's an opportunity to actually make sure they report through the integrated performance report as an integrated approach, because health inequalities feels through every bit of everything we do. So
Yeah.
happy to have an offline conversation if I can.
And the other thing I think that would be useful for this board, because delegated authority is given to the committee around the funding, the specific inequalities funding. So as part of that update, we'll be able to come back to discuss the formula that we've agreed around how that funding will be allocated, and also, very importantly, how we're going to monitor and evaluate the work that comes from that funding.
Evaluation, yeah. So I won't rehearse those comments. All agreed? Yeah. Agreed as presented and as noted in discussion. Done. Good. Item 20, the Suffolk Mental Health Collaborative. Terms of reference again, Richard?
Yes, so we had a detailed conversation here, you may remember, at the board in March, where we agreed to set up the Suffolk Mental Health Collaborative as a delegated committee of the board. We agreed that subject to the terms of reference coming back. They've now been developed. They've gone through a number of different partners, different committees, including the audit committee for the ICB on the 15th of June, and they're here for sign-off.
Any comments, disagreements? Everybody happy? In which case, approved? Agreed. Thanks very much, Richard. So, item 21, the committee highlights, or minutes and highlights reports. What I'll do in the interest of time is I'll just whiz through these, and if there's any question from any board member, please raise your hand. If there's anybody on the committee or chair of the committee that wants to make a comment in addition to the papers as presented, or to emphasise from the papers, again, raise your hands. So first of all, Audit Committee, 15th of June. Noted. Thank you. Remuneration and HR, there are 3 there, 6th of June, 15th of June, and the 4th of July. Received and noted. Finance Committee, 9th of May and 13th of June. Received and noted. Quality Committee, 11th of May. Again, received and noted. People Committee, 21st of June. Received and noted. People and Communities, 3rd of May and 7th of June. Received and noted. Estates Committee from May. Again, received and noted. And then finally, Strategic Digital Investment and Assurance Committee, 5th of May. Received and noted. Good, thanks very much. Item 22, the attendance log. We're asked to receive and note it. Any questions? Otherwise, again, received and noted. Good. Any other business? This is before I come to members of the public, of course. Any other business from board members? Non-notified, but let me just look round the table. Do wave at me if you have anything. No other business. Great. Next meeting is the 26th of September. And then that now takes us to questions from members of the public. I know Mike, commonly known as Jim, sorry about that, Mike, earlier. I know you've got one. Let me just go to Simon first. Simon, has anything come in on the streaming? Nothing at all. Joe, are you aware of anything? No, in which case, Mike, I'm going to go to you and the microphone's with you now.
Thank you, Chair. I'm sorry to say I'm back here. I've been flogging a dead horse since September of last year, I think, and fundamentally it concerns community health provision within the Felixstowe Peninsula. And I was recently contacted by one of the members of the 3 PPGs representing our 3 surgeries who have been in discussion with various bodies with regards to what provision looking forward will be needed. And there's been a deal of discussion as to how many dwellings may be being delivered across the Felixstowe Peninsula. The figure started off, I think, at 2,740. That's been amended now to 3,244. But figures I were able to obtain actually shows a figure of 4,197, which is a considerable increase on that number, but that figure is only based across 3 parishes of Felixstowe, Trimley St Mary and Martin. The other parishes, of which I currently represent, of which there are 11, are obviously contributing more residents, more patients for the 3 surviving surgeries that we have, making greater demand without being resourced. Now, what the PPGs are concerned about, it would appear that £782,000 has been approved by the local district council from the community infrastructure levy without any conversation, it would appear, with the 3 practices. And if you look at that figure for the potential 10,000 additional patients we're going to have coming into our community, that works out at about £78 per head. I'm not sure what sort of community medical health facilities you could be providing with such a low funding figure. And I think we need to look at Felixstowe Peninsula in its entirety. It does have a community hospital. You are looking to increase the population by 1/3. That community hospital really should be looked at in how it could be more effective going forward. It could possibly have a diagnostic hub attached to it. The X-ray machine that it had for years and years has been cannibalised to keep it functioning, met its death, I think, a couple of years ago. We really feel that there needs to be a broader look across our whole piece on delivering much more community health, which would remove pressure on our general hospital. More things could be done in the community. And this isn't only a problem of Felixstowe Peninsula. We have a significant building programme going on in Maltisham, on the BT site. We also have another development that will be happening at Saxmundham very shortly. And we need to get a grip, I think, of local government working with the NHS and others to do the best we can and to ensure the community infrastructure levies that are raised are actually used but are of the appropriate amount. So I don't know whether we're in a position for this board to explain why only £782,000 was the figure agreed on when they didn't really know how many dwellings were going to be a part of the 2 local plans coming forward. That is over 23 sites, and they are building out at different rates, but 5 of the biggest are currently being built, being occupied, making demands on our surviving 3 cities. So if we could perhaps move forward. I know Maddie is in the process of making some meetings, so I'd be very grateful for an update.
Okay, no, thanks very much, Mike. And just while Maddie thinks of how to answer that, there's a number of questions you're raising, from accuracy of numbers to provision of funds for whatever number, and to provision of resources and future planning. But also the really interesting point I think that you raised as well was around integration and working together and plan, which actually came up at the Health and Wellbeing Board in Suffolk that, well, we both attended last week, didn't we? And there was a great focus there on working together and integration between health and local authorities, which actually I was very pleased to hear. Yeah. So with that thread, Maddie,
yes,
over to you.
absolutely. Thank you very much. So thank you for that. So I'm really pleased to report that the demand and capacity planning work for Felixstowe and the broader communities into Trimley and beyond is nearing completion, and we have been in discussion with our district council colleagues, with our ESNEFT colleagues, our social care colleagues, in the integrated neighbourhood teams, and of course with GPs in order to get this position. And we have also now, as you know, received some really important feedback from the local community with the survey that was undertaken and led by them, and for which we're very, very grateful. So this has now been brought together, and we have a series of meetings over the coming couple of weeks to kind of check this understanding with the people that have participated so far, prior to a steering group meeting, and we've offered 2 dates to that, and to which you are invited, either at the end of August or the start of September, at which we'll be able to look at this position together and to look at what, therefore, the objectives and the priorities are for Felixstowe and the wider area. I should also, of course, have mentioned the Friends of Felixstowe Hospital, who are also have been engaged and have meeting, Nick, with your colleagues and the Friends in August also. So I think we are getting close to a position of understanding and of creating the forward plan together for Felixstowe, and that will come back to the Alliance Committee, and then we would be very pleased, I think, to bring it back to this board in public as well when we're ready. Thank you.
Okay, so work in progress to Alliance, then back to board. Okay, thank you. Nick?
As you know, we're always looking to see what additional services that we can provide in the community rather than relying on the acute site. I know there have been conversations around X-ray and indeed other issues for some years now. At Felixstowe, I'm very happy and keen to be involved in those ongoing conversations. I think, though, you make a very important, more general point. If we look at the growth of people living right across the ICB footprint, not least in Colchester, where we've seen an additional 30,000 people come in just in my tenure as Chief Executive there in 7 years, with an addition of no additional general and acute beds that have been funded. So I think there is a question that we need to be asking ourselves why we're absolutely driven to not rely on acute beds. It's not where people should be getting their care unless they need to get their care in an acute bed. There is no doubt that there will be the need for a growth in the number of acute beds, even if we are maximising the opportunities of caring for people in a non-hospital setting. There will be need for additional beds. And I think as a board, we need to be more closely aligned to the medium and long-term planning for the growth, which is inevitable and necessary for people in terms of additional housing. How does that reflect an investment right across the health and social care spectrum? But just now talking specifically about acute beds, so I think it's a really important point that you raised.
No, thanks, Nick. So back to that point about integration again with our local authority colleagues as well and working together. So,
I think it's more than that with respect, Chair, because I think it is, even if we maximise all of that, we do need, so we know that as in East of England we have a deficit of beds per 100,000. And we know in certain parts of East of England where we've got the greatest deficit in England when you look at it. And no matter what you do around integration and investing in community and investing in primary care is absolutely what we should be doing, there will still be a need for more acute beds, and it's simply not being addressed anywhere, and it needs to be.
Okay, noted, thank you. I'll go Mike, then Frida, then Richard. So back to you.
I was just going to say the opportunity really for your organisation and many others is when the local plan comes off for renewal and review. Because I've seen the two that Suffolk Coastal and now East Suffolk plans, and there's very little input from what we need to be doing. I think it's only 20% of our well-being and health is actually as a result of communal activity carried out by yourselves, and 80% of how well we are from other things, particularly local government delivering it. And it's not discussed, and it should be a key part of our local plans in this. Thank you.
Worth noting. Let's note that. So thank you. Frida.
Yeah, I just going on. I was actually Nick sort of went with what I was going to say in some ways. Just how does the question to Maddie really? How does the Felixstowe development and what you're doing fit into the SNE primary care strategy overall? Because it's not just one area, is it? I mean, with all due respect, I mean, I think you highlight a really important point that actually is reflecting across primary care, across the whole region and nationally. And going back to the pie chart in terms of the amount of investment in primary care is so much less than acute trust. And I take Nick's point about always needing acute beds, there's no doubt about that. But nevertheless, we still need more investment in primary care to develop these ideas, because without the investment, it's all very well sitting in groups and talking and bringing up very, very valid points. But unless we have a change of that pie chart and further investment, then we can enact the primary care strategy, which will include Felixstowe, hopefully, and look at pockets of real deprivation of primary care, because there are some areas that are very well serviced and other areas that are appallingly serviced, and we need some equity in our planning. And I think Felixstowe just reflects one of the areas that is poorly serviced, perhaps. I don't know enough to be able to validate that, but certainly Tendring, my area, is poorly serviced. So I think it's about equity and it's about a strategy across the area.
Yeah, being joined up. Let me go to Richard, and then Laura, did you want to come in? And Maddie, perhaps I'll go to you for closing comments. So Richard first.
Just partly sparked off Nick's comment about more broadly demand pressures on acute more broader. So you may recall, board members, that we commissioned a piece of work which Grant Thornton supported us on looking at a 10-year demand and capacity plan running to 2032. Alex Ryan, who many of you will know, who's our Deputy Director for Strategic Analytics, etc., came to the exec this week with some of the outcomes of that, and we were going to recommend that we actually, at our September board, have a development session around that. It's quite stark in terms of its initial findings around the pressures, unsurprisingly, if we do nothing over the next 10 years more broadly on primary care, community, acute care and social care. Even when we overlay the interventions that we've already agreed, there is still a significant gap, particularly 4 years hence. So we'd like to have kind of a conversation as a board about the so what. So we've got to make some kind of key decisions or pieces of work to get over that. Obviously, the work that Craig and team have been doing, the Future Systems Programme, is a little bit ahead for that part of the work we've described, because we've already got the interventions overlaid, but I'm aware there's still gaps in that in terms of what's expected versus what we've got now. So we thought that might be quite a good conversation for the board to have holistically around what do we think we should be doing in terms of what's shown.
Agreed. Let's take that forward, Richard. Thank you. Laura?
Thank you. I've been working with Maddie and Peter and working closely with Amanda's team around estates to very much look at the point you make around the health and care policies that sit within local plans, but really importantly the evidence base around that, because they have to be very robust. So really starting to think more thoroughly around health and healthcare impact assessments and how we use the evidence that we collectively can draw, not just from the data we hold, but from local authority to make sure that those plans are in place. I think there's 2 points to this. With new builds especially, it's also about making sure that we embed prevention principles in design. We've been working very closely in Essex with the Sport England local delivery pilot around active design principles and making sure they're embedded. And then, of course, as Frida says, it's also about the health and care provision that comes with that. So I think there's two approaches to this that we need to take. But I'll continue to work closely with Amanda's team to make sure we do this, and of course with Maddie and Peter as well. So there is work, there's wider work within the ICB ongoing as well. Thank you.
Thanks, Laura. So, Maddie, any further comments, closing comments?
Just a quick response to Frida's point. I mean, yes, they're absolutely inextricably linked, the kind of primary care, medical care forward strategy, and indeed actually the plans in terms of dental and pharmacy and optometry as well. In relation to workforce, digital and estates. And I think there'll be an update to the GP executive group this Thursday on where we are with that planning. Thank you. And just thank you to Richard. It's Alex Royan that's helped us with some of the demand and capacity work in this piece. Thank you.
Great. Thanks very much, colleagues, and that was a very useful final debate to have, so thank you very much. It is now 12:05. We actually are remarkably 10 minutes early, which is, or 5 minutes early, which is incredible, really, considering the delayed start. So thank you all for helping us get to that point that we finished on time. And I thank you all as well for a great debate and contributions today, really valuable. So with that, meeting closed for today, and see you all in September. Thank you very, very much. Okay, so what I suggest we do is have a 5-minute break, and if you can cope with that, you can cope with a 5-minute break before private meeting? Okay, so we'll recommence at 15:15. Thank you.